No, thank you. He's got a tie. I wore the tie. The tie has a hat.
I don't know, keeping this board in line is a challenge most days, but good afternoon, ladies and gentlemen, and welcome. I'm going to call to order the December 18th, 2025 Northern Nevada Public Health meeting for the District Board of Health. Thank you all for being here and happy holidays. Before we get started with the actual agenda and determine the roll call quorum, I'm going to just remark about a longtime friend of this board, Dr. George Hess, who passed away just a couple of weeks ago. So we're going to observe a moment of silence. Dr. Hess was a family practitioner, I believe, and worked primarily in his latter years at the University of Nevada, Reno, but was a tremendous advocate for this body and the work it did and continues to do here. So we'll just observe a moment of silence for Dr. Hess. Okay, thank you. And now, Madam Clerk, we'll move on to the agenda as posted and start with item number 1, which is a roll call and determination of quorum.
Chair Reese.
Here.
Vice Chair Andriola.
Present.
Board Member Anderson.
Here.
Board Member Brown.
Here.
Dr. Danko is absent. Board Member Driscoll.
Here.
And Dr. Duarte.
Here.
We do have a quorum.
Thank you, Madam Clerk. And we'll start now with the Pledge of Allegiance. Ms. Ferraza, you would mind leading us so much. I would appreciate that.
I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Probably reminds you of your days as a council member, so I knew it wouldn't be foreign to you, Ms. Ferraza. Thank you for being here. Madam Clerk, we'll move on to item 3, which is public comment.
Comments heard under this item will be limited to 3 minutes per person and may pertain to matters both on and off the board agenda. Unused time may not be allocated to other speakers. Comments are to be made to the board as a whole, and virtual public comment may be taken when facilities are available. A speaker's viewpoint will not be restricted. However, reasonable restrictions may be imposed upon the time, place, and manner of speech. Irrelevant statements, unduly repetitious statements, and personal attacks that would objectively antagonize or incite others are examples of speech that may be reasonably limited. This board carries out the business of Northern Nevada Public Health and its citizens during its meetings. The presiding officer may order a person removed if the person's conduct or statements disrupt the order or safety of the meeting. Warnings about disruptive conduct or comments may or may not be given prior to removal. Furthermore, certain disruptions of a public meeting are criminal acts as defined under NRS, which may result in prosecution in appropriate cases. We have not received any requests for public comment.
If anyone in the public wishes to make public comment, please indicate at this time. Seeing none, I'll call public comment to a close and move on to item 4, which will be the approval of the agenda. Dr. Kingsley, do we have any changes to the agenda?
None noted at this time.
Okay, thank you so much to my colleagues. I'll look for a motion.
Move to approve.
I have a motion and a second. Any additional questions or comments at the time? Hearing none, I'll call for the question. All those in favor, please signify by saying aye. Aye.
Aye.
Any opposed? Motion carries unanimously. We'll also vote on our tablets. Okay, item 5, one of my favorite parts of the meeting. Dr. Kingsley.
Thank you. At this time, I believe we turn it over to Dr. Dow for new hires and years of service in Health Heroes, and then Ms. Rubio for Health Heroes, correct? Yeah.
Fantastic. Dr. Dow, welcome.
Good afternoon, Mr. Chairman, members of the board. For the record, Nancy Dow, Division Director of Population Health. I would like to introduce to you Ms. Emily Nelson, who joined NMPH and is currently with the Population Health Division since December 2nd. She is a fellow from the University of Nevada, Las Vegas Applied Epidemiology Fellowship Program. So this is the second year we're continuing this partnership between NMPH and UNLV, which allows our department to host one Applied Epidemiology Fellow each year to support real-life work experience for a newly graduated MPH student around the U.S. So Ms. Nelson comes to us holding a Bachelor of Science in Microbiology from the University of Minnesota, and she has a MPH in Global Epidemiology from Emory University. She recently served as an ORISE Fellow with the CDC's Rapid Response Research and Surveillance Branch, where she analyzed wastewater surveillance data to support national pathogen monitoring efforts. She also previously worked with the Georgia Emerging Infections Program on healthcare-associated infections and with the St. Charles County, Missouri Department of Public Health, coordinating county-wide drive-through testing and outbreak monitoring. Ms. Nelson also brings global field experience from working on large-scale tuberculosis screening events with correctional facilities in Mozambique. And in her free time, she likes reading, knitting, film photography, and being outside with her dog, Lucky. So we're super excited to be hosting Ms. Nelson this year, and she has started out this month already working on various projects in our epidemiology program and in our chronic disease and injury prevention program. So
Fantastic,
welcome.
Ms. Nelson. Welcome to Reno. By my count, you're a gopher, an eagle, and a rebel, and we won't hold that last one against you. Go Pack. But welcome. We're very excited to have you, and you've got great leadership to learn from, so thank you for being here.
Thank you.
Thanks. All right, for years of service. First, we have Ms. Jackie Lawson, currently Administrative Assistant 1 in ODHO, and hitting her 15 years of service with NMPH. Ms. Lawson continues to provide invaluable support in the Office of the District Health Officer and this board. And she previously held roles including working with the Population Health Division and was a key player in supporting our work in IHCC and in preparedness. And next, we want to recognize Ms. Sonia Smith, Public Health Nurse Supervisor with the CCHS Division with her 10 years of service. Ms. Smith is responsible for the tuberculosis clinic as well as our community health workers team. She plays a vital role in ensuring some of our most vulnerables do receive the service and support that they need. So thank you both for your service to our organization and our community.
Congratulations to them both. I know that I get the privilege to work with Ms. Lawson almost every day, and absolute joy, a ray of sunshine in my day, that's for sure.
And next, Ms. Rubio for Health Heroes.
Good afternoon. Hold on 1 second. Okay. For the record, I'm Frenchie Rubio, an office specialist from EHS. So for the month of November 2025, Health Hero recognitions, 4 agents were recognized from NNPH, first one being Kristalina Christensen, a community health worker from CCHS that was noted for the values of compassion, collaboration, and trustworthiness. She's a community health worker who consistently goes above and beyond in her role. She not only completes all of her responsibilities with dedication and compassion, but she also continues her work outside of paid hours simply because she cares deeply about the people we serve. Her positive spirit, kindness, and resilience create a welcoming atmosphere for both colleagues and clients. She truly embodies what it means to serve with heart, purpose, and integrity. Next up, we have both Steve Kutz and Jan Hawk, both RNs from CCHS, noted for the values of adaptability, compassion, and trustworthiness. Jan and Steve work together to vaccinate an employee's really scared child. They were very kind and compassionate during the vaccine. They adapted to the evolving needs of the appointment and the child by explaining the process in every detail so that the child knew what to expect. They really gained his trust, and these are their job duties, but in the mother's eyes, they definitely went above and beyond. Next up, we have Diana Karlisek, a health inspector from EHS. She was noted for the values of compassion, collaboration, and trustworthiness. Diana's example and leadership in coordinating holiday donations for local Boys and Girls Clubs are commendable and heartwarming. Thank you for bringing the gift of giving to NNPH. Thank you.
Thank you so much. Okay, we'll close out item 5 and move on now to item 6, our consent items. Do any of my colleagues desire to pull any of the agenda items identified in 6 as consent items? Okay, and Madam Clerk, was there any public comment on any of these items? Thank you so much. I'll look for a motion to approve the consent items as posted. The motion.
Second.
Second. Any additional questions or comments at this time? Hearing none, I'll call for the question. All those in favor, please signify by saying aye. Aye.
Aye.
Any opposed? Motion carries unanimously. Okay, item 7. Mr. Fida, I believe that's your item. Welcome. Good afternoon.
Good afternoon, members of the board. So today will be a presentation and discussion and possible acceptance of the Environmental Health Services Evaluation Report. And giving the presentation will be Dr. Ralph Renger. He's here right now, so I will turn it over to him.
Good afternoon. Thank you, Robert, for that kind invite. Thank you, all board members and Chair Reese, for the invitation and the opportunity to present the evaluation findings. And I will just dive right into it here. By the way, as I go through, if you have any questions, just stop me right away. Probably better than just letting it sit till the end, and then we can just address the questions as we go. So January will be 30 years that I have been evaluating public health programs, initiatives, interventions, and so forth. And every evaluation always starts the same. We try to meet with the client, understand what those needs are of the client, and then we try to align our evaluation approach to those needs. And that's what we call in our world being fit for purpose. And this evaluation began the same way. We met, we defined some key evaluation questions, and off we went. Now, once in a while, you get thrown a curveball. And this particular evaluation was that curveball. And there were some unforeseen findings that required an adjustment in the evaluation strategy, and I think that's one of the really cool things about being an evaluator, is that you are able to make those adjustments, because our goal in evaluation, as opposed to, for example, in research, is to make sure that we give the decision makers the best possible information upon which to make decisions. So in this case, we did have to reframe that evaluation approach. But while some may see that as a negative, I actually saw it as a positive, because what it helped me understand was that some of the findings that we had, which may have been viewed more as independent, sort of freestanding findings, are actually related to each other. And there's a relationship between those findings. And when this unforeseen series of events happened, it forced me to rethink that. And I think the upside of all this, hopefully what will leave you today, is it allows us to be able to prioritize the different recommendations. So right now we have this massive report with a lot of recommendations, and the question is like, where the hell would we start? Oop, am I allowed to say that? I'm sorry, I didn't want to break those rules. I saw the rules, I'm sorry. But where do we start? And so I think in the end here, hopefully you'll be able to follow my reasoning and my logic, and we'll see if you agree with it or not, but it will give you a better place, I think, to start in terms of understanding, Chad, maybe, and Rob, where you might want to start making some changes. All right. So we started with some key evaluation questions. The two questions were, number one, simply, how does NNPH EHS compare to other similar organizations? Relatively straightforward. I would call that more of our secondary data analysis, looking for what other types of data are out there and doing those comparisons. What's not mentioned up there is about a month spent of time working through census tract data, only to find that that was a dead end. But I'm only going to report on the things that had a fruitful end today. The second evaluation question, very simply, was how do permit holders perceive NNPH, specifically environmental health? And there we were using primary data collection, surveys, and interviews. All right, so let's dive into some of the findings around key evaluation question 1. First thing we did is we compared And I have that study here if anybody wants to actually see it, but the study's here. We compared how you were doing, how EHS was doing, to a study by the National Association of County and City Health Officials, also known as NACCHO. And that study looked at 2,532 health departments, and we're looking at the kinds of services they provided. They divided those services in what they call common services and uncommon services, and that's simply differentiated by the percentage of agencies that provide those services. So on average, when we look at other health departments that are serving a similar size population, about 500,000 or so, they provide about 14 of the 34 core services. And when we look at what is being provided here, we see that they're providing 23 of those 34 services. 16 of those are common, 6 are less common. If you're wondering why that doesn't add up to the 23, that's because hazmat is something that's being dropped. So that does not account. So then the question is, okay, well, you're doing a lot. Do you have the FTE support to be able to do that? And here again, I relied on another study that had already been done, so relying on some other source documentation. And this particular study, I'm not sure I'm pronouncing the author's name correctly, but it's Beach or Beich. I'm not sure how that's pronounced, so I apologize to the author for that. But based on that work, EHS has 32.61 FTEs, but they need about another 5 or so FTEs to be able to do the work. So if we wanted to just summarize simply, based on this comparison, where I land is NNPH EHS is doing a lot more with less. That's kind of where we land with that. All right, let's go on to the next, or I'll just stop there. Any questions on that comparison? Pretty straightforward? Okay. Second comparison was looking at the Public Health Accreditation Board and their standards. And so I was using version 1.5. That database has 484 accredited local health departments in it. They have, the Public Health Accreditation Board uses 12 domains and 32 standards and has 100 measures. That's sort of what they look at when they're doing accrediting. But what was interesting when we looked at that is they actually have an EH, environmental health subscale or theme. And what they do is they pull out 25 of those measures and they say these measures would be indicative of environmental health. And they come predominantly from domains 2, which is investigate health problems, and in domain 6, enforce laws. So it's heavily weighted toward those two things. What's kind of neat about this database is it has multiple filters that allow us then to try and narrow down from that 484 to a smaller subset that more closely resemble what's going on here. So this is a graph that also appears in the report. It's just summarizing where we stand, and I'll just run through one of the bars there on the left, and then I won't belabor the rest. But you'll see that orange bar there represents what we were able to narrow down to, that 484. We were able to narrow it down to 22 local health departments that look very similar to what we have here. Okay, and we were to have a similar governance, similar population size that they're serving, and similar FTE support. So we got it down to 22. So I think that's pretty good in terms of, you know, looking at something that's comparable in terms of other health departments. And you'll see there on the left-hand side, it says that those particular accredited institutions meet about 80% of, or fully demonstrated about 80% of those 25 measures. So 80%, so 16 or 17 or so of those measures are fully demonstrated. And you'll see we are in green, and we have about half of those that are fully demonstrated. Now keep in mind again, this is against accredited institutions, so the standard's obviously a lot higher. But nevertheless, it looks like there could be some room for improvement from moving maybe some of our largely demonstrated things to making them fully demonstrated. Does that make sense? We were also able to look at the Health and Human Service Region 9, and you can see the comparisons there as well, but it's a similar kind of pattern. So if we were to summarize this, I would say that it appears, and I'm going to say the word appears because that brings me to one of the problems with the accreditation scoring, but it appears that you're doing quite well on those 25 EH standards and measures. But when you look closely at how the accreditation actually scores these things, there's an important quote in there, which I then verified with someone that did an internship with them, that the confirmation of whether a standard is met relies on the documentation and use. And what that means is when they're scoring a particular standard, they're looking for examples from the health department as to whether you've met that. And so the health department will submit some examples to say, yeah, this is how we meet that particular standard. However, those examples can come from anywhere within the public health department. They don't have to come from EH. So you don't really know, at the end of the day, how well EH is doing based solely on that, because it's a little bit confounded there. And I'm going to come back later as how we can actually turn this into an advantage in one of the recommendations. Any questions on that comparison? All right, let's move on to the primary data collection and the permit holder survey. So we had two surveys, one for the one-time permit holders and one for the annual permit holders. And the survey touched on those different areas you see there, experience with plan review, permit applications, clarity of material, and so forth. I was surprised, actually, we had a pretty good response rate. When Rob first suggested this, I wasn't really a big fan of trying to use this approach. I'm more of a meet the person in person and have that kind of more deeper discussion. Nevertheless, I think it actually provided some very interesting results. But before I go any further, one of the reasons I was a little reluctant is because when you kind of put out these customer satisfaction surveys, you're tending to invite the people to just want to complain. And so you have a big complaint bias built in. And I'm happy and was quite surprised to see that maybe well over half of those survey respondents that took the time were actually happy. And I think that's kind of unusual in this kind of a customer satisfaction survey, to see that kind of level of response in a positive direction. And I think that's something that you should take away and feel good about, that there are a lot of people out there that actually feel very good and are taking the time when they didn't need to express their satisfaction with what's going on. All right, so what did the survey findings reveal? Well, they revealed that generally people see the EH staff as highly professional, and I know we have some of them here with us today, and they were often mentioned, actually, the people here today were actually mentioned by name as those people that were very professional. They don't like the fees, no surprise there. The educational efforts they see mostly as ineffective, so they try. There's a lot of outreach efforts to try to engage the public around what it is to permit and so forth and apply and these kinds of things, but the public generally, or the permit holders generally, perceive those as being ineffective. And the unannounced visits that are being conducted around the food program, they are creating an enormous amount of tension, and I'm going to come back to that in a little bit. It's also interesting that many of the permit holders don't understand the role of NNPH and EHS specifically. There were complaints about, you didn't do a good job, Chad, with the birth certificates. Your passport processing was slow, etc. So there were those kinds of complaints, which made me understand that I needed to focus more the evaluation on those things that are within the control of EHS to be able to change. But the number one and recurring complaint, and the thing that I want to focus on in terms of the findings and the recommendation, the number one complaint is inconsistency. That comes up over and over and over again. Always inconsistency. All All right, so that's the survey findings. Now, the interview, and I think this is where some things may have been a little misunderstood internally. To prepare to do the interviews, I am not an EH expert. I know a lot about public health. I spend a lot of time evaluating food-related programs, but I don't know anything about underground storage tanks. I don't know anything about, as you can probably tell, IBD. You know, I don't know about tattooing and piercing. I know nothing of that. So I thought it would be important for me to have a better understanding of the acronyms, the jargon, those things that go along with that, before I conducted the interviews. So I spent a lot of time shadowing different staff. I met with the division director. I met with the supervisors, not all of them, to be clear, many of the seniors and many of the staff. But the purpose was not, the only purpose was, I'll say it in a positive way, was to help me prepare for the interviews. So that gives you a summary of the interviews. In the end, we did 26. We reached out to obviously a lot more than that, but there was really nobody in some of those areas that people, if they didn't want to participate, they didn't want to participate. So, you know, you can't make them do that. So do we have fairly good representation? Yeah, but not all the areas are represented. All right, interview findings. They validated a lot of the survey findings. And I won't repeat all of those there. But so that was good, that we had some validation from the one-on-one that we saw in the surveys, so that gives me more confidence in the findings. And here's the part that I think gets missed a little bit and is an opportunity for improvement. The permit holders really value the relationships they have with the staff. And as I mentioned, 3 to 4 of the staff unsolicited are repeatedly mentioned every single interview as people that they just love working with, want to continue to work with. One of them is here, and I'd recognize her today as Latricia. I have never met her before today. Happy to meet her. Her name comes up all the time. David Kelly's name comes up all the time. And again, I'm not looking for this information. This is just unsolicited coming forward, and people just happy with that. And obviously, the trust and respect is there in those situations. But the permit holders are willing partners, and every single permit holder I asked, would you be willing to take time and use your facility and use your expertise to help with the training of staff? Would you be willing to do that? And every single one said yes. And I don't think that that resource is being tapped enough, and we'll come back into that a little bit. All right. So what happened that threw everything off track a little bit here? The unforeseen revelations. As I said, the purpose of me meeting with the different staff and so forth was to prepare me to be able to do a better job with the interviews. And without asking, the floodgates just started to open, and there's concerns about leadership. And then we're operating in silos, and there's inter-program resentment. We hate the food department, and we think they get too many resources, and blah, blah, blah. And what I was troubled by was that some supervisors are very quick to blame, but I never once heard anybody take personal responsibility to say, this is my role, this is what I can do, this is how I can make it better. And I'm not much one personally for just listening to the complainers. I put out a lot of stuff in my field. People are free to criticize, but one of the things I always ask is, tell me a better way. And if we have a better way, that's good. But I'm not just listening to someone that just wants to complain. And so I was kind of disappointed that there was not that people stepping up, taking that personal responsibility. And then in shared spaces, and we've already had this discussion between Rob and myself, the language and tone didn't really reflect a professional environment. I was quite taken back by some of the places that I was sitting, the kinds of things that were on the wall and so forth, but that has been since corrected. I just think you ought to have an environment that you're not ashamed that anybody could walk in at any time and feel comfortable in that environment. And that, to me, wasn't the case. All right, so how do we take that experience and reframe the findings in a way that makes sense? I'm sorry, Devin, are you okay? Yeah, oh, okay, okay. Okay, all right. Any questions yet up to this point? All right. So I had to reconceptualize how we were looking at those findings, and I got to thinking, all right, what are we seeing? What are we seeing, and what could that possibly, what are the reasons for that? And I think I'll just dive into this and explain this as I go in the interest of time. So at the top of this pyramid is really the content. So this is really what the permit holders are perceiving or what they shared with us. And there's the list of the findings that we've already covered. I want to focus in on the inconsistencies, as I mentioned before. And the inconsistencies, one of the reasons for inconsistencies could be due to what's just beneath the surface there are the processes, right? So, for example, if we're talking about an inspection process, if we have the same inspector going in multiple times and doing it differently, that's going to be perceived, that's a process, a workflow that's not being followed consistently, and that will lead to perceptions of inconsistency. So obviously then a recommendation, if it were at that level, would be just continue to reinforce that consistency in staff training. They need to be following those written standards. We ask a lot of our permit holders to have standard operating procedures. We ought to be doing the same thing, right? Practice what you preach. And I do think, having shadowed, that different inspectors have their own little techniques that would really benefit other inspectors. But I don't think they have the time, or maybe it's not deliberate, where they're able to shadow each other. I know we have the shadowing is when somebody new is coming in, but shadowing of experienced people. We even had in Arizona a situation where they came from one county and shadowed in another county to be able to see and learn how that's done. And I think, standard operating procedures are still fluid, and I think we can make them even better if we have these if we share our best practices, so to speak. And then keep evolving our SOPs, and I think then they also become a little bit more efficient. So that would be one of the recommendations at that level. And wouldn't it be great if all our inconsistencies were only due to that level? That would be an easy thing then to fix, right? It was just a lot of training. But if we dig a little deeper, there's other reasons for inconsistencies that surfaced in this particular evaluation. And some of that relates to the structures of NMPH itself, or EHS itself. I don't want to keep saying the whole thing, but I just mean EHS. It wasn't unusual to hear, we just do our own thing. That's a direct quote. We each just do our own. It reinforces this idea that the programs are operating in a siloed way. And so if they're operating in a siloed way, you're going to get this variability between those programs. And what's really interesting about working in this particular community is it's probably, of all the communities I worked in, one of the ones that has the most permit holders that hold multiple permits. And if they're holding multiple permits and you're getting different folks coming from different programs coming across, they're more apt to perceive an inconsistency across those programs. And then we have just multiple staff doing multiple jobs. They're stretched very thin, as we noted earlier, with the FTE support and so forth. And ultimately, you stretch someone that thin, you're going to get some inconsistencies that are going to surface. So some ideas on reducing the program variability. I kind of alluded to it earlier. But this is, again, sharing and adopting the best practices across the EH programs. So I know there's a little bit of pushback on this one, but I do feel that when you see underground storage tanks, some situations even where the invasive body decoration folks were aware that we were coming, the inspection goes much smoother. People are prepared, they have the documentation ready, they maybe have people that they need to do corrective actions on site. So I think that's a practice that would be good from food, that would be good to adopt, or from other areas that would be good to adopt in the food area. On the other side of it, one thing that food does very well is they will always review the inspection report with whoever's there, the person in charge, after they finish the inspection, right there, while it's fresh in their minds, and they'll go over that. That doesn't happen in the other areas. Some of that pushback is, well, you know, the person that is running the gas station really doesn't really understand about, you know, underground storage tanks. And I'm like, yeah, you know, though, but the person I talked to in Texas who actually does the quality control for all of those, guess how they started? They started like that service station attendant. So I just feel like it's worth taking the time to educate folks, whoever's there, if you have a chance to educate them and go over that report, regardless of whether you feel they are, you know, the permit holder themselves, for example. Other changes to improve consistency could either, I'm just trying to figure out how you get this in line. So there's a couple options. Obviously, try to staff up. That could be challenging. You might be able to think about what programs you could offload. How we came to this one was, I've got hazmat highlighted there. In that first article that we did the comparisons with on the NACCHO article, one of the less common services is hazmat. And it just so happened that hazmat, when I came and started to do the evaluation, was also something that you were considering dropping. So I thought, well, maybe a good place to start would be to look at those less common programs, see what other less common programs you have, and is there a chance to offload some of those programs? And you got to get on top of this website. Okay, this website is a mess. There's way too many people involved in doing website changes, and they have varying levels of expertise in so doing. I think you need to have some kind of dedicated webmaster, or however you're going to get on top of that. But one of the things that feature it should have, which comes up over and over again from our permit holders, is some kind of tracking portal. And I know from talking to the different supervisors, they spend a lot of time going, somebody gets a call, well, where are we with this? What's going on with this? And I think you could end up saving a lot of time if you actually could, in your next iteration of the website, build in some kind of tracking portal. So people don't have to bother you. They can see exactly where they are in the process, application, plan review, whatever it is. All right, and then we have, finally drilling down here to the culture, kind of related. There's just a lack of team cohesion. There's lots of communication problems. As I mentioned, there's this diffusion of responsibility that's going on. And when I asked for what were some of the cross-cutting priorities, I didn't really get any. And I think even though you run different programs, you can find some things in common of those programs that guide your whole initiative. I happened to be fortunate enough to study under Albert Caron. He was the person that founded the whole idea of team cohesion and task cohesion. I studied with him back in Canada in '88, dating myself, but the goal is to build team cohesion. But let's not confuse team cohesion. There's two aspects to that, and I think you really want to focus on task cohesion, okay? There's task and social cohesion, and there's a great example of rowers that were studied who actually won many gold medals but hated each other because they were able to put aside their differences for the purpose of success and literally pulling in the same direction. And I think you have different folks here right now. You have some folks that maybe aren't on board with the direction, but they're not getting in the way. I can live with those folks. I can't live with the folks that are pulling in the opposite direction. And as an old coach used to say to me, you're either in or you're in the way. And I think you have some of that here. I think at some point you have to make a decision around some folks. If they don't want to pull in that direction, what are you going to do with them? And I understand in bureaucracies it can be a little challenging sometimes to make those changes, but they are clearly an impediment. Some typical kinds of things, I think you need more frequent and regular division meetings. They don't meet, and I mean right across, everybody needs to meet together. That's not happening as often as it should. And this was an idea that came from the staff. They would like to be involved in maybe some problem solving. Like, what's a case study that just happened? And it doesn't matter what program it came from. You get everybody together and you put your minds together. And I think that can build a lot of team cohesion. And I do think you need to have some cross-cutting priorities. Like, are you about performance measurement? Are you about quality improvement? Are you about community engagement? Like, what are you about that binds you together? And you need to have that clearly stated. And come back to that Public Health Accreditation Board, the standards and the scoring. I think that's an opportunity to do some of that team building. Is you have to, go through that exercise again because we're not clear how much EH is actually contributing to that score, and I think that would be an opportunity to do that. With respect to just looking at competencies sort of transcend all those things I talked about. Do we have the people that are, with the necessary skills to do what we need to do? And I do think pretty good with most of the stuff, but one area that you might want to explore is systems thinking. Are our people, and this is a quote from John Powers, they are dealing with multiple complex, it's a complex operation. It's got a lot of moving parts. And it would be beneficial if inspectors had an understanding of maybe how those parts go together when they're doing their specific piece of that inspection. And as I mentioned before, many operators are willing to work with you all in your training efforts. So actively engage them. Now, I know I'm going to hear, because I heard, well, we do use we work with some of the operators. Yeah, you use their venue, but you don't actually co-design anything with them. And it would be nice to actually engage them, not just, hey, can we use your facility, but hey, can you work with us to design how we're going to do this training? And then on the resource side, so we're wrapping up here. I know it's been long and I apologize, but I appreciate your patience. On the resource side, these are resources that are being provided to permit holders, to the public. And they basically are saying, the materials are difficult to understand and follow. And interestingly, if they see different inspectors over time, they see that as an inconsistency. Well, so-and-so was here one time, now so-and-so comes, this is just inconsistent. That's how they see the world. Or if they get a different result from the same person over time, they see that as an inconsistency as well. And I think we have opportunity here to reshape this. First of all, got to rewrite those resource materials. We got to be writing them at a grade 6 level. They have to be something that folks can understand. And many of them mentioned that they were having trouble understanding those materials. And I think you can take the opportunity in that rewrite to shift that perspective. I happen to think that if I had different eyes on a particular problem over time, that's a good thing. The more things that we can catch, the safer we are. And I think if it was written from that perspective, it would help. And sometimes what you're seeing over time is a natural progression, right? Especially in food. If there's as one of the folks said, an establishment that's a hot mess, right? Then you start with the most critical things first, and you try to get those under control. And then when you come back, you're focused on the next level of critical things. Well, those are different things. They're perceived as an inconsistency, but it's not an inconsistency. It's just a natural part of the process. And it would help permit holders to understand that. It would also help to design a lot of these educational efforts with some intention. It just seems kind of random now. Like the boot camps are good. Well, why are they good? What makes them good? What is the underlying thing you're trying to change? We call that the program theory. There's some examples of realtor training that I thought was a great example. Like, we're going to train the realtors because they're going to be dealing with new homeowners who then they can share with them what they can expect from the standpoint of permits and things that they may need to be dealing with before they purchase a home. That's a great example of upstream thinking. That needs to be shared with everybody. And is there opportunities to do that across the other programs? And then Clara, this is more along what you and I were talking about with the implementation theory. So they have a horror house. That's another one of their activities where they're using for training. What makes that successful is that it's based on adult learning principles of engagement, right? And reflection, but it's fun. It's just fun. And we have to be thinking not only about what we're trying to change, but how are we trying to change it? And we have to be deliberate about that. And if we're not, we never make that explicit, then we'll just keep making the same mistakes. Or if we have something good, we won't know how to replicate it because we're not sure what it is that makes it successful. All right, last slide. Where to start? So we have all those recommendations and all those different levels. And given that it goes all the way down to culture, I think you really need to start with culture. That's where we need to start. If I had to highlight where we wanted to, of all those different recommendations, I would be starting with the recommendation related the recommendations related to culture. And then I think you need to stabilize what I would call, I don't know how else to word it, first points of contact. Our first impression is really important. You don't get a second chance at that, as we know. And so where does the public first come in touch with EHS? It comes in touch at plan reviews. It comes in touch at permit applications, the website, and any kind of resource materials that you're providing. I really think like that's where your effort needs to be in terms of cleaning things up. So if I had to look at all those recommendations, that would be my suggestion as to where you start. That's it. Sorry it went on so long. I know, Devin, you just said 15 minutes, but
Well, you're
I needed to
ending
get
up
it all
on
out.
Santa's naughty list, but it's
That's
that
okay.
time of year where we give lots of grace.
Thank you.
So thank you for the very thorough presentation, and I'm actually going to kick us off here. I have a couple of comments, and I want to start at the beginning, as I often do. The first is I want to commend Mr. Fida for the staff report. I know it's a short one, but understand that the staff report is the opportunity for the board to first understand in a bite-sized and meaningful way the thing that's being teed up for us. So I think the staff report was excellent, and it helped me to frame the analysis, because I will be honest with you, and I think I told you this, Doctor, that it's a comprehensive report. It includes an incredible amount of work product, and we'll talk about in a minute how grateful I am for you for the report. But without the framing narrative, it's hard for us to understand as board members how to engage with it. And so I thought the staff report did an excellent job of helping me to understand what my role was. Dr. Ringer, first of all, thank you for the tremendous work product that you put into the report. I know that it took a tremendous amount of work. Certainly, you were here in Reno with us. I had the privilege, I think several of my colleagues did as well, of interviewing with you, and you really, I think, there's a lot here. And so I want to commend you for the effort, the work product. And what I did when I looked at the report is I tried to place it into 3 different categories. You may have had different categories, and your report broke it into different ways. But I will tell you, for me, I had to think about it in these ways. And my notes tell me, first, it's a bucket for EHS folks. The truth is I do not work in EHS. I do not understand all the component parts of what EHS does. It is a complicated job, and they are doing just a tremendous amount of work. The volume is incredible. The intellectual capacity to do the work is very high. Our EHS department is really punching above weight class in so many ways, as your report acknowledges. The second was what I'll call a bucket for Dr. Kingsley. And this is really where leadership has to meet the moment of the report. And I think that there are parts of this report that speak to that bucket and are very specific and directed at a person in Dr. Kingsley or Mr. Fida's position, right? I'm talking about leadership. And then the last one, which is what I want to focus my energy on, is a bucket for the board, right? I will say that my colleagues on this board are some of the most professional colleagues I have the privilege of serving with. We all come to it with different backgrounds. Some of us are elected, others are appointed. Some has background in medicine, which gives them a tremendous leg up on a poor schlub who's just a lawyer like myself. And so I had to think about it from those perspectives, because the reason why is otherwise it was pretty overwhelming to look at the report and say, well, what do I do with this thing which we have now gone out and paid to have done, and certainly it provides a roadmap for a lot of things. And so then for my part, I wanted to just point out a couple of things, and then I'll open up to my colleagues. And I'm going in order of the report, although because I was up here trying to scribble notes furiously, I have moved some things around. So bear with me as I try to talk about it in a way that will jive with your report. The first one is on page 3 of the report, and the recommendation simply notes something that I think is important for this board to understand, which is that our folks are overworked and we don't have enough of them. So you've made recommendations here which will be relevant to our board when we meet in I suppose it's January and February as we start working through next year's budget process and our own efforts to look at strategic planning. Those are already underway. I had the privilege of meeting with our staff to talk about that, but this recommendation, very important to me as a board member. Okay. Next is we jump ahead a little bit, and on page 6, I want to point out one of the findings you make is that that permit holders perceive our staff as professional. I will tell you this is what I hear every day in the community, and our EHS team is fantastic. When I go out into the community, and because I do have the privilege of being elected and also the curse of being elected, you hear a lot of bad stuff because they think that it's their time to tell you what they find redressable by government. But I often hear people say how professional EHS and their inspectors and staff are. And so I think that this was a key takeaway for me for your findings. The second page, or the second recommendation there, is more important, and this is I would put in the bucket that relates to our chair, our Dr. Kingsley and Mr. Fida, and that says that EHS should be deliberate and intentional in developing a mentoring program using exemplary staff or stars. This seems like the way, right? I think that acknowledgement is very important to me and certainly suggests that our leadership team will rely on folks in their capacity and the learning that they have already undertaken. And then my favorite recommendation, and we might have to spend just a few minutes talking about this. On page 8, you come to a recommendation, and I will call this somewhat burying the lead. And the reason why I say that is because there is a transformational comment and best practice being recommended here, which is something that I have and Mr. Brown has been critically thinking about at least for 4 or 5 years, and something that has become very important to me. And I will tell you that when we first met, I did not want to reveal any bias, and I did not want to reveal any interest that I might have in this topic. So while I understood what the meeting was going to be about, I withheld from you my interest in this topic. And that has to do with announced inspections. I am someone who has come to believe, although this is a change in my view from when I originally joined this body, and based on my experience here and in the community, I believe that this board will have policy decisions to make, and hopefully a robust discussion today about all plan review inspections being scheduled, not done by surprise. There are so many reasons for it, and of course I read some of the abstracts and white papers that you provided me. I think we are in a position to, in the new year, roll out a pilot program, if given the staff availability to work on such a pilot program, that would allow our inspection programs to be scheduled. It has a number of beneficial impacts, I think, on our community, but it is also continuing just a programmatic theme of this entity, our NNPH, about education versus gotcha moments. It's about training for the lifetime of a permit holder's permit rather than punishing them. The last thing I want to do is put people out of business who are really working hard to provide services and goods and restaurants and bars and pools for our community. And this particular section, you have outlined the reasons and rationale for it, and I could not agree more with it. And so I want to make sure that I have spent some time here on this page. And then the last thing I'll do is remark on an item under 9, which also is somewhat buried, but you addressed it at the end. And that is this question about whether EHS has a lack of team culture. And again, this is something for not me. I'm sort of the chair because I sit up here and I get to do that once a month. But it's really reliant and heavily depends on our Dr. Kingsley and his teams to make that happen. And so thank you again. I apologize to my colleagues for being a little bit monopolizing of the time, but I just thought it was a good way to frame how I viewed the report, and then I'll be excited to hear my colleagues' comments and concerns.
I appreciate that. Can I add one comment to
Yes,
the board
please.
bucket? So I've always seen a board, as you mentioned and outlined, as a resource. And I don't think that it's being used enough as a resource. You have tremendous experience sitting up there. When I had boards, if I had a problem, I would be coming to the board and saying, here's my problem, like, do you guys have any solutions for this? And seeing you in that capacity, and I would encourage that happens a little bit more.
Well, I appreciate that. What I will say is what I said at the top. These are some of the most professional people that I have the privilege of serving with, and their experience is invaluable and can't be duplicated, right? I cannot replicate the 40-plus years of service that Mr. Brown has in emergency medicine, in transporting patients and fire service. I cannot replicate some of the work that our good doctor does. Dr. Danko's not here, but also Dr. Duarte. So it is very important to me that we all come to it from a different perspective, and I'm grateful for it. Let's now turn it to the board and hear from more important folks than me, our vice chair and my dear friend, Ms. Andriola.
I feel I may not be taken as seriously, especially if I do this. So I'm going to take it off. Okay, well, because it really, this is my lane. And I can't thank you enough for the time I got to spend with you and the discussion, and I know others did too. I'll leave it to other conversations if those want to ask some of the conversations we had when you were asking me if I held credentials that I don't hold. I say that because this topic is something that I spent years studying and I try every day to live. And here's what I'm getting at. Number one, thank you. And I don't know who and how this all happened, but thank you, Dr. Kinsley, and thank you, Mr. Feda. Am I pronouncing your last name? Fida. One mark of mistake. But this is the most important subject of any organization is culture. And one of the things that I have been blessed to see at Washoe County is having a third-party entity come in. And one of the things that they had done that I've never seen done, and I shared that with you, and I'm going to share it with my colleagues here, is the fact that a lot of times a professional like yourself with lots of experience will come in, provide this analysis, look at the findings, meet with everyone, do the hard work, give the report, and leave. What the experience that Washoe County got to enjoy with the leadership that resulted in a very similar, not this topic, but not this detail, but the topic of a very similar analysis, was they actually worked with the leadership team at Washoe County and came up with an implementation plan. And you know what? I have never seen that done. And I'm going to recommend to my colleagues that we as a board, in terms of looking at being a resource, because I agree with you, a board is a resource. Our job is to look at providing the resources so that those can do the job. Because if we deplete those resources and they're not able to carry it out, I mean, that really is a function of a board. And the reality is that I also want to thank Dr. Kinsley and Mr. Fida for allowing you to come do this presentation, because I asked if that was something that was included, and it wasn't, and now it is, and I appreciate it. So everyone can hear. But what I'm going to ask my colleagues to consider, from a board perspective in the lane that we are in, is that we look at what that implementation plan is with the team. Because most of us probably have all kinds of different experiences and professional ways, but I'm going to use the example that I've experienced. When I was asked to be an adjunct professor on many of the topics that you're covering here, they gave me the syllabus, they gave me the guidelines, and then they left. Now, I was very comfortable in the topic that I was going to teach, but I had lots of questions, like what are the grading policies and attendance and all of these things. They were like, oh, it was a very very difficult thing to try and maneuver when I was trying to follow the policy. So I found myself spending a lot of time. My analogy to this is that it's the same thing as this report. There's great information in here. There's guidelines of findings. There's some things that you may be recommending that, quite frankly, maybe as folks dive deeper, aren't realistic for whatever reason, or may take a different flavor or turn, just because these are the folks that are the professionals. They're doing a great job, and they're really trying to do their best. And so I think this board has an obligation to invest in further with you coming back, meeting with the team, coming up with an implementation plan, and more importantly, what that timeline is, and a Gantt chart for that, and letting Dr. Kinsley do his job in terms of leadership, and looking at continuing to give us updates and seeing how it changes. This is just one part of the organization. Culture permeates from the very top, and it spins down. And I'm going to read a quote because I love Good to Great. If you haven't read Good to Great, read Good to Great. A culture of discipline is not a principle of a business. It's a principle of greatness. We want to be a great organization, and we have the people to do that. We have the leadership and the infrastructure to do it. But the train is moving constantly. They have a responsibility to go out and do all of these things. And so creating a carve-out time to create this implementation, in my opinion, if we don't professionally give that opportunity to go to that next level, I think that we are actually putting a lot of mis-expectations that it might get there, but it may not get there as effectively and efficiently as it should. So I feel now I can put this back on, because it is Christmas, and say that I appreciate the chair, because we have to have this.
Yeah, that's fabulous.
Yeah, and I really appreciate all of the detail, and I appreciate your analysis. I've spent a lot of time reading all of this. I again want to thank you for you really saying the way it is, doing the job that you're doing, and really showing and proving your credentials as a doctor and discipline in what you're doing here, along with your background. When I asked you your background, it was really, this is the right person. So Dr. Kinsley, thank you for bringing Dr. Renger. Am I pronouncing that right? I got 1 out of 2. So I really, really appreciate it. Thank you, Mr. Chair, for giving me the time, but I am going to make that recommendation strongly, and I can take this off if you need me to make it again.
Nope, I think we got you loud and clear, and thank you for your engagement in this iterative process. Let me continue now with Mr.
May I add
Anderson.
just one comment
of
to
course.
that? Thank you. On the recommendation, that's a really important point that you made. Look, it's just a recommendation. I don't have all the background information. I don't know everything that's going on behind the scenes, right? So, and I think that's a really good point. It's like that's my best guess as to what one should do absent all the information. And but I do ask, if possible, I like to track the utility of my work. And so it would be good to know whether you've considered those recommendations and whether you've adopted them. That would be helpful for me. So thank you.
Thank you so much for that. Let's continue, Mr. Anderson.
Yeah, starting off, I just want to think I'm on. So just want to say thank you for the report you did. Fantastic as far as the material, all kinds of notes that I took before the meeting and during it here. But just a few things I want to echo what you've said as far as, and likewise, Member Andriola, the culture. And I, same thing, I believe wholeheartedly that an organization, whether it's a business, a family, or something like an NPH, it can rise and fall based on the culture. And I appreciate you pointing that out. And I mean, really, it comes to us as a board and Dr. Kingsley to implement that with everyone. So I appreciate that. And the first points of contact, I love that focus because, again, it's something that I looked past and I never even thought about until you mentioned it. But a lot of times that's where it's at, and that communication and confidence that the folks are having engaging on that point of contact. And it also goes to the consistency. If that point of contact is not accurately or communicating well, it could be seen as an inconsistency and a concern. I mean, I've heard great things about some of our employees, true story, and
And I just want to say, I believe we've got others that are great, but sometimes the frustration is, well, my inspector was different and they said different things and wanted to go a different direction. And how you pointed out was perfect in that can also be a good thing. It can be good for us as an organization to look at different things, but it can also be that educational process. And folks that I've talked to in our community that engage NMPH, they talk about the educational side of it and the value that they gain from that. So I think those points of contact, if we're training them up well, that we can engage on that level, which then takes me to the training up well. I love the point about the intentional mentoring. Again, that's something that I personally have implemented in everything I've tried to do in life, and I believe if we're focusing on that well here, we see waves of retirements and people moving on to other opportunities. And there's, in my opinion, no better way than using those superstars to help bring that next level up. So yeah, well done. I guess a lot of what I had overall, though, is I guess looking at us as a board and Dr. Kingsley, how can we implement these items, starting with the low-hanging fruit and moving from there. I mean, it's so easy for us to get caught up in the financial side of it. Oh, we don't have the money to bring on more FTEs. We don't have the money to do this or that. But some of these things, I believe, we can be doing without that and not being so focused on the financial side of it. So that's actually, I guess, the task that we have at hand. How do we implement this? Which then brings me to the last point I wanted to discuss, is the proactive engagement with the board. That's one that I really think, and I want to say thank you to Mr. Vega. I think he does a good job of doing that. We work well together, and he'll give me a call or a text if there's something he wants to talk about. But I would say let's do more of that type of stuff to make sure that if we can somehow bring value to the group, utilize us. Mm-hmm. So with that being said, thank you very much. Well done.
And I appreciate it. And just
Great.
one follow-up comment to that is, it is a difficult thing to have to talk about the culture. As an evaluator, you want everything to go well. You want a nice positive thing, and maybe it would be just limited to, a process-related issue. And it is difficult when you get down and you go like, okay, this is the issue, to have to talk about that and bring it up. And I do appreciate the professionalism with which that was handled by Rob and Chad and everything else, because it's not a comfortable topic to have to bring up. So thank you.
Well, and thank you to you both for the iterative conversation. I will say, Mr. Anderson, you have raised an important point, and I'll sort of remark that, remember, this is one division of the work that we do here, and they've really had the opportunity to do a very deep dive. We, of course, in our strategic planning efforts after the first of the year, will be looking at a broader question for all of our divisions, all of the work that we do here. And so I think you'll have the opportunity to make some of those same important points in that process. And I know that Dr. Kingsley is committed and perhaps might want to comment on what does one do with such a report now having received it, right? So Dr. Kingsley, I'm going to turn the chair over to you for a moment and have you answer Mr. Anderson's question.
Thank you. So many of these points, already having received this report, I see it as an opportunity, and these are great opportunities. I don't see it as opposition, but the opportunity to grow. And so I'm excited for that. I think many of these team members are excited for that. We've recently had some ongoing, honest discussions with our EH team, but also very excited for an implementation plan. And I think we have the tools in place, right? We have our clear point objectives that we set. And so on the same theme, we will be coming back to you with an implementation plan with those clear objectives and all these points that you have all identified, when we were going to meet those and how we're going to work towards that, and also culture across. And that's an important thing across the district that we've been addressing and working towards with the directors and our core leadership on addressing those with that. So very excited for these points, and so saying that we will be coming back to you with an implementation plan, and I believe we will carve out part of our strategic planning in February directly for this. if not sooner. We already have dates set on many, like the website, as well as the pilot program for announced, but they're there, but I want to give a clear point on all these points for the board so that we can utilize you on those points. So just comment on those things, and I'm just eating this up right now, so I appreciate so much from the board and what they're providing here in this direction, and looking forward to where we're going to take this and how we're going to grow. And I think the EHS team feels the same way. They appreciate this, and we're looking forward to this growth and ultimately for serving our community. So thank you.
Mr. Brown.
Great report. And thank you. Your presentation was perfect. And as far as dumbing it down for a lot of us, all the lingo and everything in there. I got to say our staff, I see them sitting out there. We see them working all the time, and they did a phenomenal job, helping you to get this presentation together and also come up with your findings and recommendations. I had several notes written down, and our chair stole everything, but that's okay. But one thing that did step out was, your suggestion about the SOG, standard, the guidelines. I can't agree more. I came from a fire background where SOGs were something that we visited daily. And when SOGs do get put into place, it's something that's actually going to be visited yearly to ensure we're up with the latest and greatest. I see a lot of organizations that will implement SOGs, standard, whatever they call them, policies, procedures. They put them on a shelf. Somebody comes up for a promotional evaluation or anything else, they tell them to study them. Got new people coming in, learn them. But it's something that we got to revisit on a regular basis because things are always changing. So I think it'd be a great opportunity to make those changes once we get them in place and get help implemented. And, it always starts with the top. As the SOGs come in, they don't come to us for approval. They're going to come to the leadership of the organization, so our district health officer. So I think it's something that's well needed, and I was glad to see that put together. Great report, and thank you for all the participation from our staff.
Yeah, those standard operating procedures or SOGs, they're, as you mentioned, they're super important for new trainees to have those in place, right? But they are a living document. And if they were to share their best practices with each other, they'd be modifying those workflows to become more efficient and more consistent. So, I appreciate those comments. Thank you.
Well, I wanted to invite you, Mr. Brown, to maybe comment on this question about inspections, because I know this is something that you and I had worked on independent of this report, and so I was hoping you might speak to that.
Well, I don't want to steal all the thunder on that, but I'm so happy to hear about that taking place. Surprises, they're great for birthdays, everything else, but those surprises that come forward. And our chairman, we had a lot of input from the community on that. A lot of meetings with a lot of our stakeholders, and that was one thing that came up time and time again. And it wasn't that they were worried about something being missed. A lot of the worry is that at those times, and they show up, it's usually the busiest period of the day, and you take one of the lead folks from the organization out of the mix, for the success of the organization for that day, things start to fall behind. They get very concerned. They appear nervous, everything else that's involved with that. And so it was something that was hit time and time again. And again, with my career, having to do inspections, I always found it very beneficial to get an outline to allow them the time and the courtesy that, hey, we're coming, here's what we're going to be taking a look at, so they could be prepared. And it worked really well, and it continues to work in a lot of the areas. So really glad to see that taking place and one of your findings as well as your recommendations. So thank you.
Yeah, no, you're welcome. I know it can be hard scheduling, but I think, my heating guy tells me I'm going to show up sometime Tuesday, and I got to be there all day. So, if we give folks, some reasonable time to allow flexibility, because staff will get sick or so forth, why can't we just say, within this week we're coming? And that would probably be, enough to handle the scheduling related issues, logistics.
Thank you so much. Let's go here to Mr. Driscoll. Thank you so much for your patience. I was just sort of intuitively, I reached to the left, but I didn't mean to.
Thank you, Mr. Chair. Just the opportunity for all of us to share, I think, is there. First thing on the report, spent a lot of compliments on it. And while I definitely appreciate the report, I much more appreciate the process getting to the report. And the different directions you find yourself going in the interview, we talked about it, and having to pivot a couple of times because of direction being dictated by something not contemplated.
Correct.
And so at the end of the day, one of the biggest recommendations is about a culture. And while we're talking about EHS in general, it's really about culture of the entire organization. And culture is very difficult because you have so many different personalities and directions and responsibilities and professional requirements. But where it comes together is when there's a consensus at every level of the organization that's responsible for decision-making and outcomes. So it starts with the board. It starts with having a consensus on what is the mission at whatever level, and then management having a buy-in to that, and people coming to it and working in the true word of the consensus in business to where we look at all the issues, we boil them down to the key points, and then we walk away from the table. Not everybody's happy. Not everybody likes it, but they've agreed to do it and to follow certain directions. That then, when we get into inconsistencies today, start to go away because the consensus is that an inspection is for the purpose of doing this, which is the education piece, it's the safety piece, it's working with it. And I'll digress a little bit. One of the complaints that I've heard over years in my previous life is that, well, if you tell them you're coming, they can clean it all up and be ready for you. Okay. I don't see that as a negative. They've got their documentation correct and caught up. They've taken the things that they know they should have been doing, and it's there, and it gets going. An inspector can still see in the food industry that there's buildups in the corner that you didn't get because you knew they were coming, and they can work with it. So I don't see that as a negative. I see it as a positive on both sides. The other thing with that level as we're working through, we have the ability to have similar answers to questions, and it doesn't matter who the inspector is. Someone challenges you on a fee, we have a consistent answer as to why the fee exists and what are we doing with it. It's not out there to make the county and the district health board money. It's offsetting cut. We know that. So with that level of single understanding, that's how you get to culture. So thank you.
Yeah, and just to follow up on that point that you're making there, if somebody knows that you're coming, yes, they prepare, but that's a good thing. They are engaged in an educational process. We are preaching active managerial control. Well, what's active managerial control? It's thinking about these things beforehand. And to your point, they don't know what they don't know. And they're still going to miss those big things anyway. So why not remove that animosity? Why not let them know you're coming? My site visit was a great example. They knew I was coming and they didn't get all the ducks in a row anyway. They did a great job, but there's still things that no matter how hard you try, you just don't know, right? So I couldn't agree with you anymore.
I think, Mr. Driscoll, too, at least the white papers that I read on this topic, and Dr. Renger can confirm this, there are no measurable health outcomes that improve. And of course, we're mostly talking about food inspections, but there's also other inspections for pools and the like, different kinds of permitting process. But of course, we all are wanting to make sure people are healthy. We don't want to have foodborne illnesses or different kind of outbreaks happen. But the evidence-based practice suggests that in the scheduling of them, you really are encouraging people to adopt those best practices more routinely, and then you're digging deeper into the things that may be more significant issues because you have the time on site to spend with them when you're there, and they don't feel so adversarial, so maybe they're more likely to come to our trainings and do the kind of active managerial control that we ask them now to do, but only generally when they're being forced to do it as a fine or a punishment. And so there are definitely measurable outcomes that I believe will improve, and there's no evidence that suggests contrary. So that's why I have advocated for the pilot program in that regard and think it's a very important part of this.
And Mr. Chair, I totally agree with that. And when we start talking about culture and we start talking about, yes, we have done a deep dive into one particular element. Over time, as you have this expanded thought about how are we doing things? It affects the entire organization at every single level. How we address a customer, how we solve a problem, how we do education. Every single component benefits from a more similar way. And that's, I think, what we're talking about. And we have the opportunity to dig deep in a particular area, and that gives us the foundation for going across the board over time.
I couldn't agree more. Thank you so very much. Keen insights. Dr. Duarte, the floor is yours.
Thank you, Mr. Chair. I don't have a lot of thoughts because most of them have already been covered, and that's a good thing. I think from a population health perspective, what I'm looking at, I agree the process is very important. I was looking to see what outcomes do we want to define, and what does success look like. And I think that's a conversation we all need to have and the upcoming board retreat. And it's going to take me some time to process through your very thorough report to kind of define what I would consider those endpoints. But that's what I'm going to be looking at.
Understood.
Yes, Ms. Andrew-Gola.
I would just like to add, I really cannot feel any stronger word of thank you for having you come. And I know I've already said, extended a deep appreciation for Dr. Kinsley having you come and do this presentation. Because, as I had earlier mentioned, this is just one area, right? But the information that can actually come from this report from a cultural standpoint can permeate throughout and then create that good to great. And I think the fact that you were willing to be flexible in what you had called adjusted to the curveballs also is an indication of why I'm at least looking at the board considering having you work with the implementation, not to do the implementation, but to work with the leadership to create the plan. Because when you're too close to something, even though you realize and recognize, oh, he mentioned this or this finding, sometimes you are so close to it that you don't necessarily have the ability to maybe step up higher and look at it from a higher level. I think the assessment of where this started to where it's at now and where it can go is far beyond this department. Far beyond, and can really have that good to great in every discussion, in every peer-to-peer, whether it's outside, external, internal. It doesn't matter whether the board is being advocates, how we see that. I really feel that 2025 and ending this and looking at what 2026 can be is pretty powerful. But I am just going to bring it back to at least a recommendation again, of looking at just creating and being a part of that implementation with the leadership, and what I saw the benefit of that I've not ever seen happen before is just something I'm asking the board for consideration. Because again, when you're too close to something, and I'm not talking about doing a big report, I'm just talking about literally working through, these are the findings, how do we get there, what do we do? Not having Dr. Renger be the person to do it, but have the team do it with the leadership by Dr. Kinsley. That model and that exercise can then be implemented throughout other departments and other opportunities to get NMPH at the level that we all know Dr. Kinsley wants, and all of the employees are there to rise to it. So I just wanted to clarify my recommendation and what I was really trying to get at a little deeper. So thank you again, Mr. Chair, for the opportunity.
Ms. Indriel, I think Dr. Kingsley hears you loud and clear, and it certainly will be within the purview of the possible motion that's identified here that would include that. I want to go to Mr. Fida for a moment. So, Mr. Fida.
Thank you, everybody. Merry Christmas.
You're not out of here yet. Mr. Fida, thank you so much. And look, I want to make sure that you hear from me very specifically, but also hope that you hear from the board. This report was not in any way designed to speak ill of, your department, the work that you're doing there. I want you to understand I value your leadership tremendously, and this report is really the opportunity for us to get better as an organization. And I take it, given our interactions, that you've seen it that way and view it as a positive. Of course, we're all trying to get better in our own personal lives, professional lives. Everything we do is an effort. I think it's sort of human nature. One of the things I would ask is if you can tell us you've read the report, probably some of your team or all of your team, or maybe every person in the department has read the report. I don't know. What is the sense or mood about some of these things? And of course, in particular, I'm interested to know maybe initial reactions to this question about scheduled inspections. How is that being received?
I was going to say, I think the scheduled and unscheduled inspection, it's like almost like a coffee and tea debate, right? Everyone has their own preference. There is a lot of arguments that people throw for pro and for con. One of the arguments I hear for unannounced inspections is you get to catch them operating as they normally do. You get to see the normal behaviors and stuff like that. And then I think, as Dr. Renger mentioned, right, there is an element on the other side where you can prepare all you want, but ultimately what you don't know, and ultimately those behaviors still creep up. You can't change who you are and how you practice things overnight. So I think it's generated some discussion amongst the staff regarding it. I know there was some concerns regarding I guess kind of the scheduling component of it, kind of committing and what happens if something runs along or anything like that. I know there are logistical concerns, I think is the best way of describing it. So
yeah, it seems like things that your team will work out in the new year as we explore this opportunity. I suppose I'm looking maybe for you to confirm what I think I understand, because quite frankly, folks do reach out to us as board members, but I hope that even in the debate about coffee or tea or, mint chip versus vanilla, we all know mint chip is better, that the conversations are academic and that they're polite and respectful. I mean, I make an assumption that the folks on your team are highly educated, and so they have opinions, and we would expect them to have opinions. And so my hope is that they would engage in this process in a way that is respectful of perhaps change. Oftentimes change is a difficult concept and people are reluctant to it, but maybe on the other side we are made better by the robust debate about which one of those is things. I'm a coffee person in the morning and a tea person in the afternoon, so I like it both. That's really my thought process. And again, I appreciate your leadership and your willingness to engage in the iterative process that this report generates.
I know I've had discussion with some staff members, and I think well, as Dr. Renger put it, it's being intentional about it, right? So ideally, I think staff are opening to piloting this and seeing and then measuring some of those outcomes. And I think from a public health perspective, the question is going to be, what are we looking at, right? Are we looking at violations? Are we looking at cases of foodborne disease? Are we looking at outbreaks? What are these measures that we are looking for, and is there a measurable impact?
Well, and I think Mr. Anderson commented very specifically on that, about those measurables and those kind of things. We all, in our personal lives and public life, are trying to measure outcomes and make sure we have data to support the decisions we make.
Yeah.
So I appreciate that. Thanks so much.
Yeah.
Let me see if any of my colleagues have any other questions. And then Dr. Kingsley, I don't know if you have anything to say before we close out this rather lengthy item.
Do you want to look at colleagues first, or any other comments?
I didn't see any, but I wanted to make sure that you had the last word. You're the boss.
Yeah. This was a wonderful guide and a North Star for us to achieve and work towards, and I highly appreciate this. When I first began here, this had started with CCHS, and we had a report on that, and we pulled, made a few changes from there and been able to adapt, and then we went to air quality and now environmental health, and we're going to continue that process dedicated to where we can go through and identify those points. And so we have Dr. Dow's and as well as ODHO and AHS next as we're going through this process to identify how do we dig up the roots and re-nourish them and strengthen us for a future. So I thank you for the direction of the board that has guided us through this and brought us here. And so looking forward to this, and especially for the next portion of it, of the implementation plan, as well as what we're going to do for the community and really connecting with them. So thank you guys for this involvement and this direction that we've heard loudly and we'll be moving towards. And Dr. Ranger, looking forward to working through our implementation plan and have you as a consultant with that. We'll be able to make that happen. So thank you for the direction today, and excited to continue to work with the board and the staff and the team on this. So thank you.
Thank you. If there are no other questions from my colleagues, I'm going to make a motion, and I'll move to accept the Northern Nevada Public Health Environmental Health Services Evaluation Report and direct Dr. Kingsley to implement it as directed by the colleagues on the dais today.
I'll second, Mr. Chair.
Thank you so much. Any other questions or comments? Hearing none, I'll call for the question. All those in favor, please signify by saying aye. Aye. Any opposed? Motion carries unanimously. Dr. Renger, thank you so much. Happy holidays to you. Safe travels. Thank you so much. Appreciate you. Okay. Madam Clerk, lots of presentations today. Let's move on to item 8. Item 8 is a presentation by Ms. Lord on PFAS health and regulatory impacts. Thank you for your patience. It was, I know, something a lengthy presentation before, and so hopefully.
Not a problem. I work in EHS, so it's all very interesting to me. And
fabulous.
Like
that I
hear
love
about
to
it.
hear. That's who this is mostly for anyways, right?
Yes.
So thank you so much for being here.
Thank you. So members of the board, my name is Latricia Lord. I'm a senior environmental health specialist. I lead the septic and well construction team, as well as the safe drinking water team under Dave Kelly. So I'm the senior, and then he's the supervisor. And I'm here today to give a brief presentation on the health and regulatory impacts of PFAS in drinking water in Washoe County. Sorry, wasn't ready. I tried to keep this, in the interest of time, tried to keep it really high level. A lot of acronyms, for that I apologize, but it's part of the vernacular. So I plan to cover what are PFAS chemicals, what are some of the pathways for PFAS chemicals to enter drinking water, the health concerns of these chemicals, the regulatory requirements for public water systems in Washoe County, as well as a private well sampling grant that has been received by NNPH from the Nevada Division of Environmental Protection. So PFAS chemicals are per- and polyfluoroalkyl substances, and it's a category of human-made chemicals used since the 1930s, 1940s, that were made to resist water, grease, stain, heat. And as many of you may already know this by now, but they can cause serious health problems when exposed to over long periods of time, as well as during certain life stages, pregnancy, childhood, early childhood. Many of them have been largely phased out, but since there are so many, they are still prevalent in everyday environment. Because they were made to be so durable, they have been nicknamed forever chemicals, and they are very hard to break down, and therefore we have very widespread exposure found in soil, water, air, and various consumer products that we all probably use every day to keep our food from sticking to our pans as we're cooking, things like that. So because here in EHS we have a safe drinking water team, and so that is going to be our primary role when it comes to PFAS. The pathways are quite extensive. I don't want to read through all of them, but obviously we're going to have industrial releases that could lead to wastewater that are potential wastewater going into our lakes and rivers, atmospheric transport coming back down through rain and snow through the hydrologic cycle, and then any accidental spills that we might encounter that obviously we want to control, but we can't. So some of the documented health effects are listed here. Cholesterol, I wasn't quite sure about this one at first, and then as I looked into it more, it primarily has to do with how the PFAS chemicals can interfere with how the body processes fats, as well as we're going to have possible immune system suppressions, thyroid disruptions, potential kidney or testicular cancers, and then other pregnancy-related risks. Those are all been documented, and then there's quite a few other emerging concerns and tests being done when it comes to immune development, fertility, and increased risk of cardiovascular diseases. The biggest concern and the hardest to quantify is going to be the fact that many studies have shown that multiple different compounds, even at low individual concentrations, when added to, or when present together, create an additive effect that can be hard to quantify. So this slide and the next slide will kind of be regulatory background and then a look forward as far as where EHS is going to be involved. So NNPH currently regulates 69 public water systems in Washoe County. These are small water systems that serve groundwater, or they are a consecutive connection to Truckee Meadows Water Authority's surface water system. So in Washoe County, we have the main Truckee Meadows Water Authority surface water system, and then the Incline Village GID surface water systems that pulls from either the Truckee or Lake Tahoe. And those two systems, water systems, are regulated directly by NDEP, Environmental Protection. Here in NNPH and EHS, we regulate 69 other water systems. Every 5 years, EPA then requires monitoring for contaminants that may be present in drinking water but have not yet been regulated. And this is known as the Unregulated Contaminant Monitoring Rule. UCMR 3 happened between 2013 and 2015, and it was for community and non-transient, non-community water systems, and I'll explain that second term here in a minute. Serving greater than 10,000 people for 30 different contaminants, 5 of which were PFAS compounds. All of the results from that sampling event from water systems in Nevada, across all of Nevada, were below the minimum reporting limits of 70 parts per trillion at that time. UCMR 3 or 5, is currently ongoing, happening between 2023 and 2025 for numerous public water systems, all of which that serve greater than 3,300 people, and then another nationally representative sample set, for 29 additional PFAS compounds and lithium. Obviously, since it's still ongoing, data is still being collected and compiled, and to date, 1 Washoe County water system has had PFAS data reported to EPA. But they still have till the end of 2025, obviously, to even sample as well as compile the data. So how this relates is in April of '24, the final PFAS rule was announced by the EPA, with initial monitoring required by 2027 and then compliance with the maximum contaminant levels that are established in the rule by 2029. And for that rule that was established in April, there were 6 PFAS compounds, 5 of which were from that UCMR 3 monitoring, and 1 additional that EPA had enough information on. So this just kind of gives you the background of how regulations in the EPA world are developed. Of those 6, 2 now have an MCL of 4 parts per trillion. So in 2013, 2015, we were in the 70 range. Now we're down to 4 for 2 of them, and a 10 parts per trillion for 4 others of the 6. So then in November of '24, NDEP contracted with Broadbent and Associates for a grant to offer PFAS sampling to all Nevada water systems. It was free sampling, still ongoing. We have one that I just connected today to try and get them so they can at least get their initial sampling covered, and we can start getting an idea of what kind of levels are throughout Nevada. Then in May of 2025, the EPA announced a plan to possibly extend compliance deadlines for 2 of these compounds that were issued in that rule in 2024, and then stated that they may rescind or reconsider the regulations associated with the others. So it's kind of in flux. And then they also stated they plan to establish a federal exemption framework for some public water systems. I haven't found much more on that yet, so it's just kind of a wait and see. But in the meantime, whenever there's a new rule established by EPA, NDEP will go through a process to be granted primacy. And so the next section on that kind of explains that process. They have told me they plan to request a 2-year extension to the timeframes that are required or that are set forth by the EPA to obtain that primacy. It will not extend those 2027 or 2029 deadlines, but it would then give primary authority over the enforcement authority over any items associated with PFAS in Nevada directly to the EPA. They do also plan, as part of their primacy request, to allow any data for PFAS samples collected since 2019 to be used towards any of that initial monitoring. So anything that was collected during this current UCMR 5 that I was referring to should apply. So that initial monitoring and how it's going to affect our Washoe County water systems is listed there. Public water systems serving greater than 10,000 people will be required to collect 4/4 of samples, and then serving 10,000 people or less or equal to will be required 2 samples within 12 months for initial monitoring. And so what this means is there's 34 water systems of that 69 in Washoe County that we regulate here at NNPH that will be affected by this rule. Once NDEP achieves primacy from the EPA or is granted primacy, NNPH staff will assume regulatory oversight for the PFAS rule associated with these public water systems. And to explain the community water systems, there's quite a few small little mobile home parks in our community in the Truckee Meadows area. There's the town of Gerlach, Sutcliffe, Empire. Those are all small communities, as well as non-transient, non-community water systems are industrial complexes. We have 2 schools through Washoe County School District that are public water systems, Pleasant Valley Elementary and the Natchez School. And then we have other large industrial complexes that have enough employees that come to work every day, but they don't live there. So those are water systems. The Gold Ranch Casino, for example, Mount Rose Ski Resort, they have enough employees on a regular basis that they qualify under this rule. So just give you an idea of who's affected. There are quite a few treatment and funding options already available for PFAS. Granular activated carbon and ion exchange medias are both considered best available technologies already on the market. Reverse osmosis also works well, but it's going to be more effective in smaller quantities and volumes than what a public water system might be utilizing. There's also numerous funding opportunities available through NDEP to these Washoe County water systems, through the State Revolving Loan Fund, the Bipartisan Infrastructure Law, and then there's an Emerging Contaminants and Small or Disadvantaged Communities grant that NDEP processes and implements these grants, but we work very closely with the staff at NDEP to try and get our water systems connected to possible funding sources. And if you recall from last month's meeting where you accepted a grant from NDEP to NNPH for private well sampling of PFAS, we have been granted approximately $228,000 that will provide for private well sampling. We're estimating approximately 300 residents of private individual wells that are not part of a public water system to sample their well, to give them an idea of what they're drinking, and to also get an idea of what kind of levels might be in local aquifers. The grant deliverables are listed there. I won't belabor by reading them all, but I just wanted to include our planned completion dates for each step. We do have until 2029 to spend out the grant, but obviously we want to try and get it out there and take advantage of it and get some sampling and take care of it in the first of the year. That is all I have. If you have any questions, I'm happy to answer them.
Okay, Ms. Lord, thank you so much. A fascinating topic and something that I know very little about and am interested to know more about, so thank you for that. I'm going to turn this over to Dr. Duarte, who had requested this item be agendized at a previous council or a meeting. So I just want to make sure that the floor was yours.
Thank you, Mr. Chairman. I was very pleased to learn that you've got the study going, and I look forward to seeing what the data tells us and how it informs us about our drinking water. So thank you very much for your work.
Thank you. You're welcome.
Let me see if my colleagues, go ahead, Mr. Driscoll.
I'm not very familiar with what starts at EPA and ends up with us, so educate me just a little bit. When EPA sets a standard, do they also then set what compliance look like and what the repercussions of non-compliance is?
Yes, yeah. They will institute monitoring requirements, and usually for something like this, even if it was a brand-new water system that needed to comply with existing standards, it's usually going to be 4 consecutive quarters of some sort of sampling, so you get an idea if there's any seasonal fluctuations, and then they will establish what levels need to be achieved, and you need to be below in order to be in compliance.
So when that works down through the primacy of the state and comes to us as the people that are responsible for ultimate compliance, how does that work?
We are literally reading the Code of Federal Regulations and how they've written it out and interpreting it and utilizing our partners at NDEP who are working directly through EPA to gain that primacy, and we're asking for guidance and assistance and consistency so that we are just like in EHS, all things EHS, we're asking for them to help us implement these rules consistently across Washoe County as they are throughout the rest of the state.
Thank you.
Yeah.
On the left.
I would just say thank you so much. It's definitely an awareness that we all are hearing about in various ways at various levels, and sometimes that spurts up depending on what has been discovered. And I'm just wondering, are there what I would call areas in the community that are being monitored? I know you outlined, obviously, the various guidelines of timing and that kind of thing, but are there areas, because there's other organizations and entities and agencies like TUMWA, for instance, and I'm sure everybody's working together in some cross way, but I'm just curious what they are.
Yeah, so to offer explanation of, when it comes to Truckee Meadows Water Authority, they actually have 6 different water systems that they operate. They have their main water system that the primary sampling point is at the Chalk Bluff Treatment Plant off West 4th, and then maybe their Glendale Surface Water Treatment Plant that serves the majority of the valley. And it is considered a surface water treatment plant because the majority of their water is coming directly off the Truckee. They have 5 other water systems in Washoe County that they operate that are all on wells only. So we at NPH actually regulate those 5.
Okay.
One of which is out in Wadsworth.
Yep.
And they've already tested, and they are at or above the limits that are established in the current rule as it reads. And they are already in the process of submitting to NDEP for a water project and for treatment and one of these available technologies. And they have a timeline that in order to do so, they may barely meet that initial 2029 timeline, and they've already started, versus some of these other systems haven't even maybe sampled yet, for example.
Thanks.
Yep.
Okay, any concerns? Mr. Anderson.
Thank you for the report.
Yeah.
What a wonderful topic to get to cover, huh?
Yes.
So I was actually wondering if we've thought far enough out, once we become responsible for the compliance oversight, what do we foresee as far as staffing, training, operationally, how we're going to make this work within an NPH? And that was kind of my question that I had.
I would usually confer with my supervisor. It will depend greatly on what kind of results we see. coming in. We receive a monthly report from NDEP of all water quality data that is entered that meets any sort of trigger. If it's half of an MCL, depending on what the item is, nitrate, for example, can cause immediate acute health effects. The MCL for that is 10. Well, if anything's above 5, we are alerted to it, just so that we know. And then there's other items that are maybe more aesthetic concerns and not necessarily health concern that we are alerted to if it's just over the limit. So until the broadbent sampling is maybe wrapped up or the UCMR5 is all compiled, it'll be hard to tell how many systems are maybe above the limit. And I would also refer back to the one out in Wadsworth that is already treating. There is another water system in between us and them that is in Story County that is also treating and going through the process because they are downstream of our wastewater effluent from our community. So if anywhere, I would see it on the eastern side of the county.
Okay. And just one more question, if I may.
Absolutely.
I'm just curious because some of us here are either actively involved on the TUMWA board or have been. And I know one of the things that they've been struggling with is the balance of making sure the public is educated, but not causing hysteria. Are we kind of planning through a communication process, especially now as it's moving closer? And I think it's going to be more publicly acknowledged what's happening. So I'm just curious how we're looking at that.
So one of our grant deliverables for this grant is setting up a website that includes educational materials, at least to the private well owners, but it will also be utilized and available and helpful when it comes to regular public water systems. I did just learn within the last couple days that there is another grant. There's always more grants, so this is great, especially with some of the current or recent federal grant uncertainties. But there is another one that if a water system is known to be above the limit, that water customers of that water system can apply for a small countertop treatment unit just for their drinking water. So it won't be huge volumes that they could utilize or run through it, but it is coming kind of down the pipe. So once we get more data, we would be able to know who to send them to.
Okay, thank you.
You're welcome.
Thank you so much, Mr. Brown. Anything? I suppose I would say a couple of things in response to my colleagues' good inquiries. First, such an important topic that we just do not have a lot of information about. I was proud to serve on TUMWA for 6 years, and we're just starting to understand the conversations around PFAS. And I think Mr. Anderson's right that a lot of it is just trying to make sure that that's good information going out and not disinformation. I suppose from my perspective, what I want to avoid is sort of embroiling public health into a new area for which we don't receive funding. And so a lot of this starts to bleed into that. And another example would be relatedly to say, this is the kind of presentation that I would like to see made at TUMWA, potentially made at Regional Planning Governing Board where this question has come up. Because sometimes what happens is well-meaning folks in the community see a development and they react by pushing whatever lever they think is appropriate in their objection to that development oftentimes. And they might say, well, this warehouse or this home or this residential development is going to be next to a place where we heard one day there were PFAS things there, and therefore we're not going to do a thing there for all time immemorial until the experts figure out PFAS. And I don't, it's a very hard place to be put in because, of course, none of us want to expose people to some dangerous thing that might harm them and their children. And you have a lot of information here about some of those very real and serious harms. But it's like reacting out of sort of ChatGPT-driven conspiracy theories versus reacting to science. Those are sometimes the disconnect. And so I wonder if the takeaway for me from the presentation is A, awesome job, B, take the show on the road, which might be something that we can talk about offline, and C, just sort of a cautionary warning about the role of NNPH in this space, and maybe that's the one thing that I might ask you to address, just if you know, or if Dr. Kingsley or your team would want to say, like, what is the role that we might envision for ourselves in this space outside of this, the grant that you've already identified?
Mm-hmm. Well, when it comes to the regular everyday compliance for the public water systems, that is, we do that work underneath a grant that is provided on a regular basis. I don't know how much that is on a regular. It covers staff time across the board and has for quite a few years. We used to regulate the main Truckee Meadows Water Authority surface water system and the Incline Village GID water system, just for an example and for reference. And that was then requested to be turned back over to NDEP because they regulate numerous other public water systems that serve surface water, primarily all of Clark County. And in turn, we began doing the chemical compliance portion. So just for a history of what our role has been and where it would work into the workload. And I don't know if Dave has any other comments when it comes to the workload, and he would be the one determining that.
Yeah. First, Latricia, wonderful presentation. Thank you for coming and bringing this forward. Historically, I think the last time that the public really, where we saw education was with the flooding of Swan Lake, and we needed to be able to address that. And it began, and then it kind of died out, correct? And so we are continuing forward with this. And anything that we permit, so this is where when unfunded or we get mandates or those things, when we permit, then we're able to recoup costs. So that is the one thing here. It's the educational pieces or private wells that we have to seek those loans out. So I would say bonus point on that this is something that, within we're able to regulate because we permit, so then we get a feedback. So this is something we can, is sustainable for us to do on those points. And so it's always evaluating that. So anytime we receive more, then that's when we have to reevaluate our fees on those points. So it's always that process. So we do have a way to make it sustainable. Concerns where we're at currently is that we've seen progress in this, but as mentioned in May 2025 was the first talk of rescinding all of these. So there is talk at the federal government of rescinding many of these points that we would no longer have to regulate, which is a challenge because on one point we hear we want healthier food, we want healthier water, yet we're going to pull back the regulations from our corporations that enable that. So working with our federal partners to monitor that and hope that we can continue those. There was up to 6, and then they went up to 8 PFAS that were acknowledged to were carcinogenic, and I believe they did pull those back, unfortunately. They had started down that road, and then it was pulled back. So we see a lot of ups and downs here, but I see in our community this desire to move forward, where in Nevada we are very well specific. And we have Truckee Meadows. I think it's just where we will work with our board, Truckee Meadow, Tumwa, and making sure that what's important is our water and our health of our community. So while we may see fluctuations in the federal government, I think it's something here that we will always monitor and listen to our public where we can and where we can deliver. So thank you.
Such a time to be alive. And certainly we're all reacting in real time to things outside of our control at the federal government level, so no problem there. I just wanted to make sure that I emphasize that I hope we were not engaged in some kind of mission creep with a new thing, and it's a fancy thing. You explained it beautifully to me, and so now I understand. And again, I'll sort of emphasize the point I did make, which is take the show on the road. I think you've got something here that the public would like to know about, and maybe they're not always paying attention to NNPH, but maybe they would be more receptive at somewhere else, like Tumwa. And I know Ms. Andriola serves there and is the chair, so you got the right people. So thank you so much. Yeah, fantastic, really informative, and I'm very grateful for Dr. Huarte for raising the issue and for your presentation today.
You're welcome.
Okay, thank you so much. I think, and I'm not sure, was this item for action or is it just, no, it was not. Okay, thank you so very much. We'll close this item out now and move on to our next presentation. Ms. Shepard, been incredibly patient waiting for us to get our show on the road, and a topic that I was very interested in and I think asked for. So thank you so much. Appreciate you.
You're welcome. Good afternoon, members of the board. Christina Shepard, Division Director for Community and Clinical Health Services. Today, I'm just going to give you what I hope is a brief overview of sexual health services offered through our Family Planning Sexual Health Clinic. So this is just some STI numbers at a quick glance for Washoe County. I think the key takeaways here are that over the past 3 years, our STI rates have remained fairly steady. We are still finalizing our 2025 data. I will point out that please don't get too excited about the congenital syphilis number. In a recent update from my colleagues in population health, we actually are now up to 15 congenital syphilis cases for the year. So I think that trend is going to remain steady. When we look at Nevada's STI rates nationally, the latest year we have data is 2023, and Nevada ranked in the top 20 nationally across all reportable STIs in 2023. Most of that was driven by rates in Clark County, but I would say what is particularly concerning for Washoe County is that we do have high rates of congenital syphilis and primary and secondary syphilis. So the Family Planning Sexual Health Clinic provides accessible, client-centered care focused on reproductive and sexual health. Our clinic's mission is to reduce barriers to care, support informed decision-making, and promote overall health and well-being through education, prevention, and high-quality clinical services. We don't turn anybody away due to inability to pay. Our fees are based on income and family size, with special provisions for teens seeking confidential care. So who are our patients? Well, most of our patients are between the ages of 15 and 44, which is considered the reproductive age range. About 60% are assigned female at birth, so we see about 40% that were assigned male at birth. A couple of things to point out here is that nearly half of our clients are uninsured, which makes access to care a real challenge because they're having to pay cash pay at other places that most likely don't have a sliding scale fee for services. And then even among those with insurance, many face barriers like not having a primary care provider or having really long wait times for appointments. And then around 70% of our patients report incomes below 250% of the federal poverty level. So just a little bit of context there, for a family of 4 that is at 150% of the federal poverty level, they earn about $48,000 annually. And then we do have a significant portion of our clients that identify as Hispanic or Latino, about 50%. So I'm not going to talk too much about our reproductive health services. We have been providing reproductive health services since Title X began in 1970. But I do want to highlight a couple of crossover services. So every patient that comes in does receive a comprehensive sexual health history, as it is a key part of understanding overall health and identifying appropriate testing or screenings that need to be offered. Per CDC guidelines, we do offer chlamydia and gonorrhea screening to all females 24 and under who come in for reproductive health services. And then anyone with a positive pregnancy test is screened for STIs that day, and that includes an in-house syphilis test if they're eligible for it. After their positive pregnancy test and testing, they are then referred to a community health worker for a warm handoff to prenatal care so that we can get them hooked in with prenatal care as early as possible. So our clinic does offer comprehensive STI testing with same-day results for chlamydia, gonorrhea, syphilis, and HIV. We have treatment available for most STIs. Both the recommended and alternative regimens are available on site, so it eliminates the barrier of people having to go to a pharmacy to pick up medication. They can get their medication just from us. And then all services are delivered with client-centered counseling. We engage clients in practical, respectful conversations about their sexual health and how to reduce their chance of acquiring a sexually transmitted infection. So over the past few years, we've really expanded our prevention services, especially around HIV, and this was in direct response to patient feedback and changes in community provider availability. We had a lot of patients that were coming in for testing who were very interested in PrEP for HIV prevention, but weren't able to get it through their primary care provider or at any other community provider location. And so we implemented oral daily PrEP about 2 years ago. And we are currently in the process of implementing injectable PrEP, which is a brand new intervention as well, which is super exciting. Our community health workers have been instrumental in our PrEP efforts because they serve as our PrEP navigators. So they help patients access medication, manage prior authorizations, and stay on track with their refills. We also offer post-exposure prophylaxis for HIV treatment. So this is treatment that needs to be started within 72 hours of a potential exposure to HIV. So we do try to prioritize these patients due to the critical time frame that they need these medications. And then I apologize for my typo, but we've been trying to transition them from PEP to PrEP. So if they've needed a PEP regimen, then they likely are a good candidate to transition to PrEP. We also work very closely with our HIV colleagues in population health to do what are called rapid starts, which is an initiation of HIV medication within 1 week of a positive HIV test. This has shown to be very effective in reducing that person's ability to then transmit the virus to somebody else, and also shows really good health outcomes. So the sooner you can get somebody started on antiretroviral therapy, the better that their outcome is. We also do doxy-PEP, so antibiotics that are taken within a certain time frame to reduce a chance of acquiring certain STIs. So in studies, this has shown really, really good prevention or post-exposure prophylaxis for syphilis and chlamydia, not so much for gonorrhea, but is another exciting intervention that we've implemented in the past year. And then we do vaccinations and partner services. Partner services also involves partner-delivered therapy for some sexually transmitted infections, and then testing and treatment for partners that may have been exposed. We continue to offer free community testing at our center, Washoe County Sheriff's Detention Center and Eddy House. These sites allow us to reach vulnerable populations and provide education and resources in addition to testing. And then we've also worked really hard to raise awareness about our services. Through partnerships with NNPH's communications team, IC Media, and Commando, we've been able to launch a couple of different public service campaigns across dating apps, social media, billboards, and radio. So the one on the right was one that ran on the dating apps, and then the kind of two on the left were our billboard, social media, radio ad push. The clinic does face some challenges. I would say the biggest one is funding. The instability at the federal level has made it really difficult to plan for the long term. So because of this, we've had to delay filling vacant positions. So the clinic currently has 6 vacant positions. And this has led to a longer wait time for appointments. So people are waiting on average 2 to 3 weeks for a scheduled appointment, and our walk-in appointments fill up very quickly during the day. The good news is we have received approval to hire a second APRN, and we are actively recruiting for that and hoping to have somebody on board in February. And then access in the community is still very limited. We are the only clinic that offers walk-in appointments for sexual and reproductive health services. So it's very hard for somebody that has multiple competing priorities to find a place to go to get services when they need them. And then I would say changes to Medicaid and Affordable Care Act incentives are going to likely increase the number of uninsured clients that are relying on our sliding scale fee for services. So not extending the tax credits for those Affordable Care Act plans starting January 1st, I think we may see an increase in the number of uninsured people versus the number of people that are on private pay. So I wanted to keep it brief, but I'm here and happy to answer any questions, and I have my phone a friend colleague here if you have questions about specific STI rates. But I do want to take a moment to recognize the incredible staff in the Family Planning Sexual Health Clinic. Despite limited resources, they show up every day and provide exceptional and compassionate care to our patients. So I'm very proud to work alongside them. Thank you.
Okay, thank you, Ms. Shepard. Outstanding presentation. Let me turn to my left first and see if anyone has questions on this side. On this side. Dr. Kingsley, and then I'll go.
I just wanted to, sometimes in storytelling, it receives an impact, and so just Christina's team. So there was an individual within our community that had spent over 2-3 years, I believe, trying to resolve a medical issue that she had, and with various treatments. And by coming into our clinic by chance, she came in with a simple wet mount that able to diagnose and cure her. And so sometimes the expertise that we have out in our community, we have wonderful doctors, but they just don't see it as frequently as we do. And the fact that we were able to, Christina's team was able to meet that and cure her and change her life after 2 years of struggling with a diagnosis of what is going on, that we simply were able to do it here. So we do provide very specific, and again, being the only walk-in clinic in Washoe County is a difference that we do, that we meet that community. That's where we are, with that stopgap, that individuals that where we help in the community. So I just want to recognize on that story and the impact that we do have with individuals in our community.
Thank you. Yeah, I will never forget my first patient that I started on PrEP. An older gentleman that had been trying for years to get on PrEP. He had resources, had insurance, had a primary care provider, and was never successful. And so it was just it felt like such a big win to be able to get him onto PrEP.
Yeah, well, thank you for that comment. A couple of things. First, as a sort of an apology, we put you on a very busy agenda 6 days before Christmas. And I want you to understand that if I could go back in my time machine, I would not do that, because I do think that this is a topic which we could spend an enormous amount of time. So my thought is perhaps we will find time during our strategic planning workshop to revisit this topic.
Sure.
Very important to me and our community personally. I wanted to ask one question that was not covered in the report or in the presentation, and maybe see it's a sort of a gap in my knowledge, and this is about rapid HIV testing and whether that is available in this community in any way. I have been in other larger communities, and I have seen it. I've not had the chance to participate. I would like to, but I wonder, is that something that exists in Northern Nevada, and if so, who is doing it? Is it what can you tell me about that?
So we do rapid HIV testing in the clinic. That's pretty much exclusively what we do is rapid HIV testing. We rarely draw a lab-based so that people have their results that day. Rapid HIV testing is also done at our community testing sites, so at our center, at the jail, and then at Eddie House, we're doing rapid HIV testing. There are some other providers that are doing, like Planned Parenthood. I think Hope's Clinic does rapid HIV testing. I think CHA does rapid HIV testing. I would say like your run-of-the-mill primary care provider is likely not providing rapid HIV testing, and I don't believe they're doing rapid HIV testing in the ERs.
Okay, so clearly you can see the gap in my knowledge base in this area. And I suppose my interest is because I had a constituent come to me and say, hey, I am doing this event, and his name is Ray Lutsky.
Yes.
And he is doing an event with NNPH, and I saw the advertisement for it, so I was very excited about it. I'm out of town when the event is happening, but I was very encouraged that the fact the event was occurring. And I think he had asked me, he wanted to have rapid HIV testing on site, but maybe he didn't understand that we didn't do it in that way, or there was some reason why he wasn't able to couple that with the event that he was hosting. And again, why I asked is because this constituent raised the question with me.
Yes, I'm Jennifer Hall, for the record.
Thank you so much.
Sexual health program coordinator, or supervisor now.
Congratulations.
For like 2 years, and I forgot that. So yes, we do know about that event. We do have limited funds for the community-based testing that is paid for out of the staffing, and the tests for the HIV tests are paid for out of the CDC HIV prevention grant, which we don't know what that's going to land with, like funding-wise. It ends May 31st. My plan was to have our community health workers direct people to our center and to NNPH for testing.
Awesome. Great. Thank you so much. That gives me the opportunity to respond in real time to the inquiry. And again, my apologies to both of you for the length of our meeting today, because I do think there are probably more questions that might be asked under different circumstances. So I'm going to hold on to the report. I'm going to look to my colleagues left and right to see if anyone has any additional questions. It doesn't look like they do, but please know that this is a topic that I will be interested in following up with you about.
Just so you know, April has STD Awareness Week in it, so maybe that's a good time as well.
I would love that. Dr. Kingsley, make that happen for us. Thank you so much for the presentation. I appreciate it.
Thank you.
Okay, now we're going to close out item 9 and move to item 10. And let me also, just for a roadmap for folks and for those watching at home and in the audience, by just the chair's prerogative, a couple of these items are going to come off the calendar today in the sake of preserving our quorum and getting everyone back to their regularly scheduled assignments. Items 13A, 13B, 13C, 13D will not be heard today. We'll accept them as written presentations only, and if any of the board members have questions on those items, we will take them up individually and offline. And then I think that is all the items that I am going to remove at this time, and we'll see what we can get to in the next couple of items. So I'll close out that item, move now to item 10. Item 10 is a presentation by you, Dr. Kingsley, and you've come off the dais to make it. Thank you so much.
Yeah. Thank you. So Dr. Chad Kingsley, District Health Officer for the record. Just going to go quickly review over. Last month, we received our data from 2025 mosquito season. So I just wanted to get direction from the board as well as essentially our 3 jurisdictions as it may impact our budget this year on presenting and moving forward and looking at that. So this was previously presented. Again, we're looking at that 3 years data. When you look at that graph real quick, that green one in the back is when we didn't start, and so we saw mosquitoes rise, and then right when we started the aerial larvicide, we see it go down. We see the purple one where we delivered correctly across the system that we kept mosquitoes down, and then the orange one is this past year, 2025. We had a favorable season right up to August, and then we saw the mosquitoes go up. So we see the impact that doing our aerial larvicide does and what it is for our community. And so the mosquito abatement, you previously saw this and the work that we did, so I'd be presenting this to the county commissioners on these points and just showing this is kind of what an average year looks like us when we were doing mosquito abatement. So updated our numbers from 2025. We saw numbers of dengue fever, and again, those yellow ones that are there are, though we do not have the mosquitoes that transmit or carry these diseases, so individuals that had been traveling came back to our community, had this, so it wasn't acquired here within our community. But as looking at it, a lot of our mosquito abatement came from the early 2000s with West Nile, the increase of it. Over the last year, over the last 5 years, we had 1 case, so looking at that. And then, so just looking at NRS really. So there's NRS 439 and 318 and 439 again. And that just allows us the authority for the extermination or abatement of mosquitoes and other vectors at the health district. Really, the DHO allows me to designate to be able to do that. It gives us certain property rights and to go on to property for abatement. And NRS 318 is a creation of special districts for mosquito abatement. Any special districts, so the commissioners are allowed to create these districts. They would have to find funding for it as an option, and just comment on that. So recently, Clark County Commissioners did discuss creation of a special district in Clark County for mosquito treatment. Tentatively looking at it, though, it is very cost prohibitive. But anyway, essentially, so these statutes empower us as myself as well as the District Board of Health. The only recovery costs that are actually in RS is to put a lien on a property. And so that is very lengthy. It can go on for years, and it's not very popular. So that's why it's not used. But that's the actually only really recovery costs that we have the option of. And mosquitoes is really not going to be that. That would be more rats or other vector things on there that somebody perhaps is not cleaning up. Then we can put a lien on their property, but that could take years or up to the sale of that property. So currently, right now, we do not have a dedicated funding source in our statutes for abatement, just the authority to do that. So previously funding, so 2005 to 2010, during an optional flood and public safety sales tax, so 1/8 of a cent of tax was imposed by the county commissioners. So 5 years, this is the 2005, 6, 7, 8, and 9, and 10. Those are the amounts that we received in Northern Nevada Public Health at the time for abatement on mosquitoes. It was relatively new, as that's when really Zika came out and they were doing that, so that's previous there. Then in 2017 and 2018, post-flooding, The general fund contingency transfer was approved, and in 17, $205,000, and then $534 in 2018 was provided in Northern Nevada Public Health. Any of those gap years and up to present, the rest of the abatement has been absorbed through Northern Nevada Public Health EHS. So last year, as we brought to the board with our budget struggles, we did suspend the large area treatment for fiscal year 26, so this past season. Though it was one of our largest expenditures, that doesn't impact our staffing, is why we moved towards that, and it was, in our consideration, the lowest risk that we had with only one Zika case in here. So that saved us just about $300,000 last year in our fiscal year budget. So looking forward as we move forward, currently this is what it costs for us to run a season. And this is as efficient as we can. We have about environmental health services, so we do, when they're not doing a mosquito abatement, we have them doing plan review, pools, tattoos, schools, and those inspections, so looking at that. So a supervisor over them, a senior, and one EHS, so these are all our EHSs that go down to the field. To supplement that, we use interns at $15 an hour, so on average we get about 3.3 of them, 3 to 4 to 3.5 that we use from May to September, and they go out and do our trapping. They help us, so it's a way for us to do it as economically as we can. Mosquito abatement, the helicopters where we cut back last year, but we have our overhead charges. We also have a warehouse, that's about $51,000 where we rent and do utilities. That's also where we do grow our fish at and keep those supplies there. Then a vehicle cost and operating costs was like that. So about $830,000 for us to run this abatement costs. So Public health has a number of unfunded mandates that are a must, that we must do, and authorities that are a may. Mosquito abatement is an unfunded authoritative may. So we do not have a must on it, on that, but it is one that is more in the public's eye. And so we have, as a nuisance that we have moved out towards to always address since 2005. Federal, state, and local public health funding lessons that we're required to, so prioritize risk and impact for delivery of services on all health programs, and explore alternative funding sources for low to no risk authoritative may activities. So that's kind of where we're at with our budgets. So I'm just trying to help us be able to provide a clearer path forward. This is necessarily just going to the commission, but representing the three jurisdictions to say, is this an interest to us that we would like to ask the commissioners? And they can say no, we're all in budget constraints, but it just allows us to better understand our budget moving forward. So this is what I put forward to you, what I would go and present to the commissioners for their consideration.
Okay, any questions from the board? Ms. Andriola, I'm particularly interested to know for your perspective, because I think when we had the discussion this summer, you were the one who probably got the most feedback from the community. It wasn't, I did not hear about it, but I think maybe your area where you represent may have more possibilities for this to occur.
Well, I'm not sure exactly what to add other than I think to a certain extent we all were receiving some feedback based on the decision by this board to, and upon the recommendation of Dr. Kinsley to at least, I'll use the term pause, the mosquito abatement with the helicopter, which as you listed is $281,000. And I want to actually use this opportunity to thank you and the staff, because there was a lot of confusion as if the program was entirely going away, which is a little bit of a segue of what you're sharing. So we went from maybe just pausing the helicopter to how do we even sustain this? So I really don't have much to add other than to say that I think the fact that the helicopter crosses all jurisdictions. The helicopter doesn't stop on the line of unincorporated Washoe County or the city of Reno or the city of Sparks. Mosquitoes, I don't think, can be bred to actually identify jurisdictional boundaries. So all I'll say is I don't know enough about this. I actually noted the fact that there was the 8th cent tax imposed by the Board of County Commissioners that you noted in your slide. I'll reserve the opportunity to continue to research this and look at maybe having discussions possibly with what that impact. I do think it is always interesting to put on anybody, no matter who it is, an unfunded mandate that in this case has the language of may versus shall, which is you have no choice as an entity. So I think it gives room for further discussion and exploration, and I'm going to use that opportunity, Mr. Chair, to do that. Thank you.
Thank you so much, Ms. Andriola. Any other questions from the board? Okay, I'll move to approve the presentation on mosquito abatement funding and approve the present data and future funding options to the Board of County Commissioners.
I'll second it.
Okay, any additional questions or comments at this time? Hearing none, I'll call for the question. All those in favor, please signify by saying aye. Aye. Any opposed? Motion carries unanimously. Okay, well, that'll close out item 10, and we'll now move to item 11. Item 11, that's you, Mr. Kelly.
Maybe we can train mosquitoes together. Good afternoon. For the record, my name is David Kelly. I'm a supervisor with Environmental Health Services. The item you have before you is a business impact statement for some proposed changes to the regulations governing sewage, wastewater, and sanitation. More specifically, the sections that we are addressing pertain to residential septic systems. As you know, anytime regulations are being updated, we present a business impact statement to the board pursuant to NRS. I'm just going to highlight a couple things. I gave you guys a lot of information in your packet. In the staff report, I mentioned that our team started receiving feedback about 10 years on our regulations. About 2.5 years, we actually started engaging with drafting them and engaging that process in earnest. And then approximately 5 months ago, with the shutdown of the Donovan Pit, we lost our only source for engineered and advanced treatment septic systems. And that created a little sense of urgency as part of these regulations will help address that issue. The reality is almost, I'm going to say all, of these regulations are based on the needs of industry. And there is in no way more restrictive or costly to industry. That's our final conclusion on the business impact statement.
And Mr. Kelly, that is the key finding and recommendation.
That is the key finding, yes.
Understand.
And I believe that sincerely.
Understand.
So, just a couple of examples. Right now, if you cross a water course or a drainage, you would have to go through a variance board and process. That's about $3,000 in a 1 to 2 month timeline. As I mentioned, the sand filters, this opens up alternative technologies, which the industry has available, but our regulations just have always been a little bit behind the times, and this opens that door. And in addition, it opens up for contractors and homeowners to use additional licensed professionals other than engineers for percolation tests. We felt there are other qualified professionals out there, so that will increase access to for those types of services and hopefully reduce costs on them as well. So again, as I said, the final finding is that there's no negative impact. There are also no fee increases associated with these proposals. I mentioned in there that we made a few changes, I think 8 based on public feedback, both from industry and the state Board of Health. Or not the board, but State Health, we talked to them. I've received word from legal, so the draft that's posed is the final draft. There will be no additional changes. Legal's okay with it. State Health is okay with it, and they were posted on the 8th of December, just those additional 7 changes. If you do approve the business impact statement, I'll be back before you next month, and we can have more in-depth conversations if you want to, but I'm also happy to answer any questions about the business impact statement, about our outreach, or any of the regulations that you might have.
Mr. Kelly, thank you so much. First of all, a couple of things. One is thank you for the great care that you took with me to help educate me about the topic. It was not something I was particularly aware of. It's a strange thing when you get into office, you have to know a little bit about a lot of things. And the concern that often can be raised is that we don't desire to see unintended consequences of the actions we take based on our lack of knowledge, but you made me feel very comfortable with the action we were taking. I appreciate the care and thoroughness that you undertook in terms of the timing of the review, the multi-year process. I understand that, we haven't changed our process since 2013, and so that seems a fair cry from where we are today in almost 2026. Thank you for the public workshops that were held and for the thoroughness of the engagement process. I note for the record, and so the record is clear, that there were a lot of people who engaged in those, I think attended by 65 and 35 property owners, engineers, installers, realtors, people who have a real stake in the outcome of these kind of regulations. And it's on that basis that I am able to make all the findings necessary to move forward with the motion that's identified in the staff report. So I want to make sure that for legal compliance needs that we have done that. Any questions from my colleagues on the board?
Mr. Chair?
Yes, Mr. Driscoll, thank you so much.
In reviewing all the documents were there was the one that's the final regs, if you will. In that, there are numerous figures that the title tells us that they're to be updated. So I reached out to staff and received an answer that we're dealing with the business impact statement, and the type of very fine changes to some of those figures do not change any of the language and do not change any of the regulations. There simply will become the best schematics that we can do at the end, and they may or may not change, which is why they're left that way. So we're not approving that. We're only approving the business impact statement. And so while the document says final, I'm comfortable voting that while it's an ancillary document, that it is in flux. Thank you.
And just to clarify, I probably should have called out. I think the draft that I posted, if you look, it'll show a figure that says to be updated. But right before I posted it, I got my digital thing. So if you look underneath it, there's a cleaner picture, and that is the intended picture. So, and you'll have a final copy in all the red lines next
Yeah, thank you for that. Any other comments or concerns from the board? Okay, I'm going to close this item, and I'm going to make a motion to approve and adopt the business impact statement for the proposed revisions to the District Board of Health regulations governing sewage, wastewater, and sanitation, with the finding that the revised regulations do not impose a direct and significant economic burden on business or citizens, nor do the revised regulations directly restrict the formation, operation, and expansion of the business, and set a public hearing for the possible adoption of proposed revisions to regulations for January 22nd, 2026 at 1 p.m. Any additional questions or comments from my colleagues? Hearing none, I'll call for the question. All those in favor, please signify by saying aye.
Aye.
Any opposed? Motion carries unanimously.
Thank you.
Little did you know that my high school debate career would pay off in being able to read fast. Okay, item 11 is now closed. Item 12 is, I'm not sure how much discussion we'll need, but I'll bring Ms. S. forward. She's already here. Look at that. It sounds like this is a reappointment of Ms. Dean. Is that correct?
No, it is an appointment of. So, Chair, members of the board, Andrea S., Preparedness EMS Program Manager, for the record. Today I'm here asking for the appointment of Cassandra Dean to the MSAB Hospital Continuous Quality Improvement Representative. Ms. Dean is currently works as the Director of Clinical Excellence for Renown. She comes highly recommended from her predecessor, Mr. Joe Macaluso, who recently gave his resignation and wanted to pass the torch. Ms. Dean was also the only applicant we got for this position, but we do find her well qualified and look forward to her expertise and to help move the board along. This position holds a term of 3 years and then eligibility for 2 additional 2-year terms.
Thank you so much, Ms. S. And I apologize, I had indicated a reappointment, but it was the appointment of Ms. Dean. If my colleagues don't have any questions, I'll entertain a motion. Okay, I have a motion from Mr. Brown.
I'll second.
Second from Ms. Andriola. Any other additional questions or comments? Hearing none, I'll call for the question. All those in favor, please signify by saying aye.
Aye. Aye.
Any opposed? Motion carries unanimously. Item 13, A, B, C, and D I've removed, but I have left item 13E on the agenda, and that is for you, Dr. Kingsley, for any time that you might need with us before we break for the new year.
None at this time. Thank you.
Okay, I should have removed you as well, but I didn't. We'll close that item out. Item 14, Madam Clerk.
Comments heard under this item will be limited to 3 minutes per person and may pertain to matters both on and off the board agenda. Unused time may not be allocated to other speakers. Comments are to be made to the board as a whole, and virtual public comment may be taken when facilities are available. A speaker's viewpoint will not be restricted. However, reasonable restrictions may be imposed upon the time, place, and manner of speech. Irrelevant statements, unduly repetitious statements, and personal attacks that would objectively antagonize or incite others are examples of speech that may be reasonably limited. This board carries out the business of Northern Nevada Public Health and its citizens during its meetings. The presiding officer may order a person removed if the person's conduct or statements disrupt the order or safety of the meeting. Warnings about disruptive conduct or comments may or may not be given prior to removal. Furthermore, certain disruptions of a public meeting are criminal acts as defined under NRS, which may result in prosecution in appropriate cases. I do not have any requests for public comments.
Thank you so much, Madam Clerk. We'll close out item 14 and now move to item 15. Item 15 is reserved for board member comments. If anyone has any, now is your time. Dr. Duarte.
Yes, I just wanted to mention that the PFAS chemicals are present in multiple sites, not just the water. People can get them from food and clothing and other household items. So this is not just a drinking water problem. And the health effects are still being defined, but it's looking like there may be some significant health effects related to ingestion and chronic exposure to these chemicals. So that's why I think it's important that we look at this.
Thank you so much, Dr. Duarte. Any other questions or comments? Ms. Andriola.
Well, I don't have any questions, and I feel like I just want to wish everyone a Merry Christmas and a wonderful time with family and friends. And I have created a motto for December of a no-scale zone in my home for the whole month of December. It may change in January, but it's not going well. I cheated today and on the scale, and it is not going well. So on a very serious note, I really appreciate the opportunity to serve on this board, and I certainly appreciate the opportunity to get to know everyone, and everyone brings so much complementary experience and professionalism to the board. I'm going to celebrate that and taking that away from 2025 and looking forward to 2026. And I hope everyone has a blessed holiday. Thank you.
Thank you so much. Any other comments or concerns? Okay, I'll just take the opportunity to say, of course, Merry Christmas, Happy Hanukkah, whatever holiday you're celebrating, Happy New Year to everyone. Thank you to all the staff for sticking with us today. It was a longer meeting than I had anticipated, and that was because great presentations and lots of important topics. So with that, we'll move and we'll make, I'll be adjourning.
Merry Christmas. Happy holidays.